Dear colleagues, a warm welcome to the third OncoAlert Colloquium, this year being held in partnership with the American Society for Radiation Oncology, the European Cancer Organization, the European Society for Gynaecological Oncology, the European Oncology Nursing Society, the European School of Oncology, eCancer, the International Society for Geriatric Oncology, the Multinational Association of Supportive Care in Cancer, and the SWOG Cancer Research Network. Together, we bring you this end-of-the-year review of the Best of Oncology 2022, from trials to publications, drug approvals to current controversies within our field and future trends in treatment and research. This colloquium will last 6 days from January 23rd to January 28th, 2023. Links will appear on social media, and you can always find them via our website, OncoAlert360.com, and there you can find the colloquium webpage. You will find the possibility to subscribe to our newsletter, and we will send you the links daily. This colloquium is independent of any financial support and comes to you as a result of our partners and our faculty working hard in order to drive the field forward, regardless of geography. There is no sign-up, no information acquired or tracked. You simply click and watch. We truly hope that you enjoy this colloquium as much as we enjoyed making it. All the presenters have added their Twitter accounts at the bottom, and this was done in order to facilitate networking, contacting, and education. The days are separated by specific tumor groups, and our aim was to give you as much of a multidisciplinary approach as possible. Although we apologize to our surgery colleagues, we promise to have this included for our fourth colloquium. The daily links to the colloquium will be active at 12 noon EST, New York time, and 6 p.m. CET, Stockholm time. Once the presentation has been streamed for the day, it will be available to you on demand, and we highly encourage you and thank you for sharing it with all your colleagues at your institution to truly amplify the knowledge coming out of our faculty. Another way of receiving the links daily is always by signing up to our newsletter at www.OncoAlert360.com. Today is day 3 of the colloquium, focusing on the best in lung cancer 2022, and our partner sessions by ASTRO, ECHO, MASCC, and SWOG. We're joined today by an amazing faculty, Dr. Sanjay Popat of the Royal Marsden, UK, presenting on non-small cell lung cancer, Dr. Jarushka Naidoo of Beaumont RCSI, Ireland, presenting on small cell lung cancer, Drs. Henning and Amy Wisdom of Massachusetts General Hospital, USA, presenting on thoracic oncology radiation during the ASTRO session. Ms. Terri Conner, founder of KRAS Kickers USA, presenting on the patient perspective in lung cancer. Dr. Jack West of City of Hope USA talks to us about the current controversies in the treatment of lung cancer. Dr. Giannis Mountzios from the Hellenic Society of Medical Oncology, Greece, presenting on mesothelioma. We then move on to our partner sessions. Dr. Mark Lawler of Queen's University Belfast in Ireland, presenting the ECHO sessions on the European Cancer Pulse. Dr. Ian Olver of the University of Adelaide, Australia, discussing financial toxicity during the MASCC session. We finish up with Dr. Charles Blanke, chair of SWOG, discussing SWOG trials in 2022. Without further ado, Dr. Popat.
Well, hello everyone. My name is Sanjay Popat. I'm a medical oncologist at the Royal Marsden Hospital and the Institute of Cancer Research, both in London in the UK, and I'm delighted to give you this highlights of 2022 for non-small cell lung cancer as part of the OncoAlert Colloquium. It's been an extremely busy year in non-small cell lung cancer. So these are my disclosures. And what we're going to talk about over the next few minutes is an update on what's going on in the metastatic setting in terms of targeted therapies, the metastatic setting in terms of IO, and then we're going to shift gears into the radical setting, update in targeted therapies, and the radical setting in IO, where there's quite a lot happening. So let's just dive straight in. Metastatic non-small cell lung cancer, what's been happening with targeted therapies? Well, most of the year, a lot of the action's been about the KRAS setting. And first of all, we had the exciting data at the ASCO 2022 annual meeting where Dr. Spira presented data from the highly anticipated Crystal-1 phase 2 trial. This is the monotherapy study of adagrasib at the recommended phase 2 dose, 600 milligrams BID, for patients with relapsed metastatic G12C mutation positive KRAS non-small cell lung cancer. Primary endpoint of the study was overall response rate, and what we saw is that the overall response rate was about 43%. Interestingly, in this study, Dr. Spira also presented data on intracranial activity, which we hadn't really appreciated with sotatercept before. And here they demonstrated an intracranial response rate of 33%, 21% in patients with non-target lesions and 54% in patients with target lesions. And you can see in the bottom right-hand panel of the graph that the waterfall plot is really quite impressive. And more importantly, median intracranial progression-free survival was 5.4 months. And these are patients with treated stable CNS metastases that were allowed. Now, when we look at progression-free survival and overall survival, we do see a progression-free survival of 6.5 months and a median overall survival of 12.6 months. But what is the price that patients have to pay in terms of adverse events? And we look at treatment-related adverse events. Most patients do get treatment-related adverse events, as we would expect. And the adverse events tend to be low in terms of frequency for grade 3-4 events, but predominantly are diarrhea, nausea, vomiting, fatigue, and we do see 28% of patients having any grade ALT rise, with 7% of patients needing discontinuation. Now, Dr. Pada had the pleasure of being the discussant of this dataset at the ASCO meeting, and Dr. Pada reviewed both the adagrasib data and the sotatercept data from the CodeBreak 100 study that had been presented today. And when we look at efficacy, we see very similar efficacies, although we shouldn't really make these comparisons directly, but we see similar overall response rates, similar disease control rates, similar progression-free survival and overall survival rates that we see between the two drugs. But perhaps there are subtle differences in treatment-related adverse events with adagrasib. We're seeing 43% of patients having any grade 3 to 4 treatment-related adverse events, 21% with sotatercept. This may or may not be due to how drugs are classified in terms of adverse events. And we see diarrhea, nausea as key frequent adverse events, perhaps a little bit more ALT rise, transaminitis with sotatercept than we're seeing with adagrasib, but ultimately the treatment-related adverse events leading to dose discontinuation in the bottom right-hand panel, you can see here is about 7% for each drug, very similar. Now, at the 2022 ESMO meeting, Dr. Johnson presented the highly anticipated CodeBreak 200 trial data. This is the randomized phase 3 confirmatory trial of sotatercept versus docetaxel in previously treated metastatic non-small cell lung cancer patients with KRAS G12C mutated non-small cell lung cancer. Patients were randomized to receive either standard of care docetaxel monotherapy at the 75 milligrams per meter squared dose or sotatercept at 960 milligrams daily. Patients were randomized 1-to-1, and the primary endpoint was progression-free survival. The sponsor received regulatory guidance to reduce the planned enrollment from 650 patients to 330 patients, which would have obviously reduced the power of the study. And also there was a recommendation for crossover in patients randomized to docetaxel to sotatercept. So what do we see? We see the primary endpoint of progression-free survival was met with a median of 5.6 months for sotatercept versus 4.5. It was statistically significant, and the hazard ratio, I would suggest, is quite important, 0.66, although many would argue that the progression-free survival advantage would be rather modest. Overall survival was not significant, with a hazard ratio of 1.01, and we can see that in the bottom right-hand panel, crossover of docetaxel patients to a KRAS G12C inhibitor occurred in 34% of patients, which obviously will have impacted on the ability to detect an overall survival benefit. The response rates for sotatercept were 28% compared to what we see 13.2% with docetaxel. And given that many of these patients are IO pre-treated, we are seeing that there's a higher response rate and perhaps a slightly increased efficacy of docetaxel post-IO than we would have seen in the historical era. Now, at the World Lung meeting in August, we had updated data on can we combine sotatercept with IO? And this has been the big question. How do we move sotatercept up to the first line setting? And here we had updated data from the Codebreak 100-101 trial presented again by Dr. Johnson. And in this study, there were several cohorts, and patients either had concurrent treatment with atezolizumab or pembrolizumab together with sotatercept, or sotatercept lead-in and then combination with either atezolizumab or pembrolizumab with the key primary endpoints of safety and some efficacy secondary endpoints. So when combining with pembrolizumab concurrently, in the top part of this slide, we see that there are very high rates of hepatotoxicity seen with standard doses of sotatercept at 960 and lower doses of 720. You can get lower hepatotoxicity with reduced doses of sotatercept, but the rates of ALT rise are really quite high. Now, this is mitigated somewhat when using a lead-in schedule of sotatercept and then adding in atezolizumab or pembrolizumab. We do get reduced rates of treatment-related adverse events, particularly hepatotoxicity, but this is not mitigated in full. And this really raises some questions about the ability of sotatercept to be combined with IO. So what about adagrasib? Can this be combined with IO, specifically pembrolizumab? And the highly anticipated combination data was presented by Dr. Yanni at the ESMO IO meeting in December at the end of 2022. And here Dr. Yanni presented pooled data from the Crystal phase 1b expansion cohort of patients treated with adagrasib, but at a lower dose, 400 milligrams BID, together with pembrolizumab, pooled with Crystal 7 phase 2 trial data of patients with the combination 400 milligram BID. And what Dr. Yanni presented was that whilst there are treatment-related adverse events seen, grade 3 to 4 occurring in 40 or 4%, the rates of ALT rise are not as high as we've previously seen in combination with sotatercept. Nevertheless, the response rates that we see in this setting, in the pre-treated setting, are about 49%. And they do vary by PD-L1 status in the bottom right-hand panel. You can see that the response rates are higher for patients with PD-L1 more than 50% and lower for patients with 0%. So based on these findings, the sponsors have said that phase 3 trials are planned in the first-line setting, evaluating adagrasib 400 milligrams BID plus pembro versus standard of care stratified by PD-L1 status. Well, what else is ongoing in targeted therapies? We've had an update on the CROWN trial data at the AACR meeting. This is an important ALK-positive trial, first-line trial of lorlatinib versus crizotinib, with the first interim analysis showing a huge progression-free survival advantage for lorlatinib. This has been updated, and again, we have a hazard ratio of 0.27, very impressive overall progression-free survival rate. And in patients without baseline brain metastases, a spectacular hazard ratio of 0.02, neuroprotective with very few, if any, events in patients treated with lorlatinib. And again, even in patients with brain metastases, the hazard ratio is 0.1. So very, very impressive in this setting. The key issue is the adverse event profile suitable for the first-line setting? We had an update on the adverse events, and you can see that the frequency continues to be as we had seen before, with moderate rates of edema, weight increase, fatigue, peripheral neuropathy, and cognitive effects observed. The EGFR exon 20 space is an extremely busy space with a lot of activity ongoing in terms of drug development. One of the drugs that is coming through is CLN-018, or previously known as TAS-6417, which is a novel irreversible oral EGFR inhibitor in broad spectrum of activity against a number of EGFR mutations, including exon 20 insertions. Here, Dr. Yu at the ASCO meeting presented an update on the ongoing phase 1 study, demonstrating an overall response rate of around 38% in the overall cohort of patients. And we can see in the bottom left-hand panel that the median progression-free survival is around 10 months or so. When we look at adverse events, we do see typical adverse events as we would expect for this group of agents which target EGFR, rash, diarrhea, but perhaps not as problematic as we would have seen before, which resulted in about 20% of patients requiring dose discontinuations. Perhaps one of the biggest news has been in the HER2 mutant space. And here Dr. Goto presented data on the Destiny Lung-02 trial with the drug trastuzumab deruxtecan at the ESMO 2022 meeting. Now, this is an important study because the previous Destiny Lung-01 trial had been based on the TDXT dose of 6.4 milligrams per kilogram, and we didn't really know what was the appropriate dose given the adverse events that we see with the 5.4 dose and the 6.4 dose. Here, this was a randomized phase 2 trial, randomizing patients between the 5.4 dose and 6.4 dose. Patients had to have HER2 mutant non-small cell lung cancer, metastatic, or received at least one prior anti-cancer treatment. We see that the response rates were very similar across the two different dosing levels, and very impressive, I should say, as well. And when we look at the adverse event profile in the 5.4 dose on the top hand of the slide, we see fewer emergent adverse events with the 5.4 dose than we do see with the 6.4 dose. Specifically, pneumonitis was markedly reduced with the 5.4 dose compared to the 6.4 dose. Any grade pneumonitis 5.9% compared to 14% with the 6.4 dose. And on the basis of this data, the 5.4 dose has been approved by the US FDA for the HER2 mutant relapse non-small cell lung cancer indication. What about our ROS1 patients? At the end of 2022, at the triple EORTC NCI AACR meeting, we had the updated data on the ongoing phase 1 trial and the phase 2 dose expansion cohort, potentially leading to filing for repotrectinib, which is a novel, rationally designed ROS and TRAC inhibitor designed for on-target resistance activity and intracranial activity. Here we had data on patients in the expansion cohorts, both TKI naive after prior ROS1 TKIs with or without prior chemotherapy. And in the ROS1 TKI naive space, in the left-hand panel, we see very impressive waterfall plot. We have very impressive response rates with response rate of 79%, with the majority of patients with ongoing response at 1 year and progression-free at 1 year. And in the on-target G2032R mutant population, which is a common mutation that we see occurring in patients treated with ROS1 inhibitors, we do see very impressive activity here with a response rate of nearly 60%. However, there are adverse events, and this drug does hit TRAC. So therefore, we do see low-grade dizziness occurring in the majority of patients. 61% of patients do get it. It is grade 1 in the majority of patients. And about 20% of patients reported the associated ataxia, with a smaller number reporting ataxia in the absence of dizziness. Well, what's been going on in the IO space? In the metastatic setting in the IO space, we've been trying to improve the outcomes of single-agent PD-1, PD-L1 for some time. We have noted in the more than TPS 50% group of patients adding CTLA-4 inhibitor ipilimumab had no improvement in overall survival from the 598 data, but that was the initial data cut. Here we have 3-year data being followed up, and we don't see any separation of the curves in the progression-free survival or overall survival, concluding that in the more than 50% TPS group, the addition of ipilimumab has no additional benefit over pembrolizumab monotherapy. However, that's not necessarily the case for all tumor types. Remember Checkmate 227, a very complex study with 2 parts. If we look at the group of patients with PD-L1 negative disease, these patients were randomized to receive either chemo, nivo-chemo, or nivo-ipi. We now have 5-year overall survival data in this group of patients, which were PD-L1 negative. And indeed, we do see perhaps an important benefit here at 5 years, with Nivo-Ipi coming in with a 5-year survival rate of 19% compared to Nivo-Chemo at 10% and chemo at 7%. Remember that Nivo-Ipi was not the primary endpoint in this part of the study, and this schedule is approved in the US but not in Europe. The similar schedule is Checkmate 9LA, which is approved in Europe. And here, this is a trial where patients had Nivo-Ipi together with 2 cycles of concurrent chemotherapy. At the beginning, we had the 3-year overall survival update presented by Dr. Pazarez at the ASCO meeting. And at the 3-year time point in the overall population, we do see a maintained overall survival benefit. Perhaps I would suggest very similar to what we've seen with Checkmate 227. And if we focus in on the difficult to treat PD-L1 negative population at the 3-year time point, we are seeing an important 25% of patients remaining alive compared to 15% of patients with chemo alone. And if we look at the KRAS mutant population, again, a difficult group of patients, we do see a small benefit in the patients with KRAS mutant disease, which is not seen in patients with KRAS wild type disease presented at ASCO. Now, the other schedule which has recently got a FDA approval is the Poseidon schedule, which was presented last year in 2021, but we had the 3-year overall survival update presented by Dr. Johnson at the ESMO meeting. Now, remember, this is a schedule of patients treated with durva, tremi, and chemotherapy for 4 cycles together with durva maintenance thereafter with 1 cycle of tremi together with maintenance. And we had the updated data from the Poseidon data. Now, what we can see is that in non-squames and squames, we have ongoing evidence of benefit, which very much seems to be restricted, at least from the durva tremi viewpoint, to the non-squamous group, with a 2-year survival durva tremi 25.1% compared to 20% with durva and chemo, and 10% with chemo alone. And specifically, if we look at the KRAS mutant population, we are seeing more of a benefit in the durva tremi chemo population at the 2-year time point compared to a smaller benefit in the KRAS wild type population. Now, the other area we've been really keeping a very busy eye on is TIGIT. What's been going on with TIGIT? So previously we had the Cityscape data, which was presented in 2022, looking at whether tiragolumab, which targets TIGIT, when added to atezolizumab, gives a benefit. And in 2020, we did see a progression-free survival benefit and a response benefit in the more than TPS 50% cohort, and this led to a number of phase 3 trials, and the key one that everybody's looking at is the Skyscraper-01 randomized phase 3 trial, in which patients in the first line setting are with PD-L1 high are being randomized to either atezo or atezo with tiragolumab. And the co-primary endpoints are overall survival and progression-free survival. This year we had a press release from Genentech which reported that the combination did not meet one of the co-primary endpoints of progression-free survival, and the other co-primary endpoint of overall survival is immature and is going to continue until the next planned analysis, although a numerical improvement in both co-primary endpoints was seen. Now, this trial will have implications given that every major pharma company does have TIGIT drugs in development, so let's wait and see what 2023 brings to this space. So in terms of metastatic IO, we've had update of Keynote 189, the 5-year overall survival, which Dr. Garacino presented at the ESMO meeting. And we see, yes, we have a big overall survival advantage at the 5-year time point, 19% of patients compared to 11% of patients. Look at the PD-L1 negative patients. Really, we've got a lot of work still to be done in this group of patients, particularly when we look at the progression-free survival. Similarly, Keynote 407, overall 18% of patients overall survival at 5 years compared to 9.7 years, but in the PD-L1 negative group of patients, still we have a lot of work to be done to trying to improve the outcomes of our patients, with very little difference really in overall survival and progression-free survival in this group of patients. So we also had at the ESMO meeting some data on who the patients are that complete 35 cycles or 2 years of chemo IO from Keynote 189 and 407. As you'd expect, these patients are predominantly patients who've had previous overall response, 86% with 189, 90% with 407. The duration of response has been very long. And importantly, the 3-year overall survival rate after completing 35 cycles is around 70% for both cohorts. So that's important data that you can cite for our patients. And those that are alive without subsequent progression or therapy is around 40% of those patients. So important metrics to cite in those patients that are discontinuing at 2 years. But should we be re-challenging with pembrolizumab, and if we do, what are the outcomes? We had updated data on this at the World Lung Meeting in Vienna, pooling data from 2 cohorts, those with pembrolizumab monotherapy, 024, 042, 598, and those with combination chemotherapy, 407 and 189. And here, Dr. Rodriguez-Abreu presented that the outcomes of patients re-challenged, I would suggest, have really rather modest response rates again, although there are a variety of PD-L1 strata in these group of patients. Overall response rates of 19% with pembro, from the pembro mono groups of patients more likely to respond, and no responses in those that were given pembro chemo previously, with median progression-free survival of around 10 months if re-challenging. And importantly, the time from stopping first course of pembro to starting the second course of pembro for patients that had pembro mono was 12 months, 1 year, and only 5.4 months in patients with pembro chemo. Important metrics again for those patients that required re-challenge. Now, the other big data that was presented were at the ESMO meeting. Here, Dr. Lee presented the important data from the Ipsos randomized phase 3 trial in patients that were treatment naive with metastatic non-small cell lung cancer, but were platinum ineligible, either because of poor performance status or good performance status, but with substantial comorbidities. Here, patients were randomized to receive either chemo monotherapy with vinorelbine or gemcitabine, or atezolizumab with overall survival as the primary endpoint. And the overall survival primary endpoint was met with a hazard ratio of 0.78. The median's improving modestly from 9.2 to 10.3. The benefit of this has been argued. Personally, I think that this is an important data set for this group of patients with significant comorbidities. And importantly, when we look at the multivariable analysis, we do not really see that there's a big separation in patients' outcomes, so survival, by PD-L1 status, which is surprising, but perhaps this is limited by their median survival and their comorbidities. Progression-free survival was improved, although relatively modestly, but response rates were improved for atezo compared to chemo. The other big data that came out just at the end of 2022 at the Singapore ESMO Asia meeting were about EGFR mutant patients. Now, when these patients have had all their TKIs and they go on to chemo, should they get chemo or chemo nivolumab? This was the subject of the Checkmate 722 data, highly anticipated, which Dr. Mott presented at ESMO Asia. Here, this was a trial which was hit by COVID, had to have substantial reanalysis and a reduction in the sample size because of COVID. But ultimately, at the end of the day, it was a negative study with no significant improvement in progression-free survival, nor improvement in overall survival. And therefore, adding IO to chemotherapy is not recommended at the moment in patients that have completed TKIs with EGFR sensitizing mutant disease. We are, of course, awaiting the Keynote 789 trial data. Now, switching gears to the radical setting, there's been a lot going on in the target setting. We've had the 3-year ADORA update, which Dr. Suboy presented at the ESMO meeting. In the left-hand panel, we had the previous data, which Dr. Herbs presented at ASCO 2020, and we can see the separation in the right-hand Kaplan-Meier for progression-free survival still remains huge, with a hazard ratio of 0.223, a massive DFS benefit for adjuvant osimertinib, but we do see the curves perhaps starting to come together a little bit. Now, when we look at stage outcomes and map on the 3-year time points, we don't see a particular excess of additional disease-free survival events in stage 1B, but we do perhaps see an excess of events in stage 2 and stage 3 once osimertinib discontinues. Is this a treatment waning effect? We don't know. Is 3 years the optimal schedule? We don't know. How should we monitor our patients? Perhaps a bit more frequently than we would do otherwise in patients discontinuing. I'm sure Jack West will have a lot more to say about this study, so do tune in to his review on the OncoAlert Colloquium. So what about the radical setting with IO? There's been a lot going on. We've had the IMpower 010 data making adjuvant atezolizumab standard of care in patients with resected non-small cell lung cancer. At the beginning of the year at the ELCC meeting, Dr. Philippe presented the patterns of relapse data, and we see that adjuvant atezolizumab has a huge role in reducing distant relapse in the bottom left-hand panel, but more modest role in reducing local relapse. We do see perhaps a reduction in second lung primary rate. Now, following up the data, Dr. Philippe then presented the updated survival data at the World Lung Meeting. This is incredibly important in the overall survival analysis of stage 2 to 3A in the left-hand panel, TPS more than 1%, we do see a survival advantage, hazard ratio 0.1, but importantly, when we stratify it by PD-L1 strata, we do see that this is very much limited to the TPS more than 50% cohort, which is now statistically significant. Hazard ratio 0.42 in this group, and this underpins the reimbursement regimes that we see in many areas of Europe. Can we use ctDNA to predict who should get adjuvant atezo or not? Dr. Philippe presented data at ESMO IO in patients who are ctDNA negative after surgery. It's not predictive. We see a benefit in patients still in the more than 50% setting, and in patients that are ctDNA positive, we still see the benefits in more than 50% positive, more than 50% TPS positive. So therefore, ctDNA doesn't seem to have a huge role in predicting atezo efficacy, decision making or not. And what about whether you've cleared your ctDNA after adjuvant chemotherapy or not? And again, Dr. Philippe presented this data showing that whether you cleared it or not, you still have a benefit from the addition of atezo. So at the moment, ctDNA does not seem to be predictive in decision-making on the use of adjuvant atezolizumab. Now, at the beginning of the year, we had a big bombshell of the Pearls Keynote-091 trial. This is an important randomized phase 3 trial, again in the adjuvant setting, stage 1B, more than 4 centimeters, 3A per AJCC version 7 of adjuvant atezo with or without adjuvant chemotherapy. Remember, IMpower 010, everybody had to get adjuvant chemotherapy. And in this study, in the overall population, we had a hazard ratio of 0.76, met the primary endpoint. Is a positive study. In the overall ITT population, pembrolizumab does have a DFS advantage. However, with the co-primary endpoint of TPS more than 50%, this advantage was not seen, and this has caused a lot of questioning with a hazard ratio of 0.12, p-value 0.14. When we look at the multivariable analysis, we see other things that don't make a huge amount of sense. We do see that in patients, there is a difference in terms of histology, non-squamous versus squames. Patients that didn't receive adjuvant chemotherapy seem to have no benefit from immunotherapy. We see a potential benefit in patients with EGFR mutation. We see no real difference in benefit by PD-L1 strata. The difficulty with this study is once you start looking at one subgroup, then we have to look at all subgroups, and then things don't really make sense. So I personally find this study very difficult to interpret. The big bombshell, I think, was presented at the AACR meeting by Dr. Girard. They presented the highly anticipated neoadjuvant chemo nivolumab data from Checkmate 816. We'd previously known that the path-CR rate was 24% compared to 2% with chemotherapy. What are the efficacy endpoints? Overall, event-free survival, significantly better hazard ratio, 0.63 compared to chemotherapy. And when we stratify it by path-CR status, it really is those patients that get path-CR that are having all of the benefit from the event-free survival. So who are these patients that are getting the benefit? When we look at the event-free survival by different strata, we do see that there is a difference by stage, but this is perhaps driven by events. This was mainly a stage 3 population. There is a difference by histology. There is a difference, a big difference by PD-L1 strata, but nevertheless, the PD-L1 negative group still seeming to have a difference, no benefit by TMB, and importantly, carboplatin having a strong benefit compared to cisplatin in this data set. And when we look at the exploratory overall survival, we are seeing an important separation of the curves, even at this early time point. Now, this data has been supplemented by our Spanish group. Our Spanish colleagues have been doing spectacular work in the locally advanced stage 3A and B setting. We've had previously the Nadim trial. Dr. Prevencio presented the Nadim 2 trial at the ASCO annual meeting here. Patients with stage 3A, B were randomized to receive either chemo and then surgery, or chemo-nivo and then surgery. And we do see a path-CR rate of nearly 37% compared to 7% with chemo, and this is different and significantly different according to the PD-L1 status, as we would expect. And with that, I'm going to thank you for your attention. It's been a really busy year. We've got a lot to come through in 2023, and please tune in to the other talks in this colloquium. We'll get updated on other areas of thoracic malignancy, and especially Jack West, who will go into all of this data in much more detail. Thank you, and thank you for your attention.
Hi, I'm Terri Conner with KRAS Kickers. Give you a couple of comments about KRAS lung cancer from a patient's point of view from 2022. 2022 went on to prove once again how important it is for patients to get their biomarker testing and to know what it is. It's not just going to be about what type of KRAS that we have. If it's wild, if it's mutant, it's going to matter if it's wild, if it's mutated, if we have a co-mutation. They're starting to see that there's evolving co-mutations, STK11, KEAP1, in addition to if we're KRAS G12D versus G12H or G12V. We've got some pan-KRAS clinical trials that are coming out that are looking very promising for people, but we also only have 2 approvals, and they both are for G12C. G12C inhibitors, great start, fantastic place to be, but it's a second-line therapy. We can see that it's going to be looking towards moving into a first-line therapy. That's fantastic, and it is doing better. At least the sotorasib did much better in comparison to docetaxel. With the adagrasib approval, now there are different options for patients and doctors to give you the right choice for that G12C, but we're not anywhere near where we ought to be. We have got to get more robust testing as it pertains to what's going on for the patients and for us to know. And we need to, even more importantly, let the patients know what they are so we can get what it is that we need to be looking for. The patient information that we get is going to be as a result of the information that the doctors are providing to us. So you all have the power to give us the information it is that we need, so we don't go climbing down a rabbit hole looking for fake information. We'll be able to get legitimate information based on the actual mutation that we have. Please provide information to your patient. Is your KRAS wild? Are you mutated? Is it a G12A, G12D, G12V? What's the difference? And then let's take a deeper look, a deeper dive into if we've got an STK11, if we have a KEAP1. The immunotherapy is really looking promising. We've got PD-L1, and that's just an indicator. But there are an awful lot of folks that are responding to immunotherapy without having a high PD-L1. What's going on with that? Where are we going to be going, and where's going to be going next? Because we've got to be working together to kick cancer's KRAS. This is Terri Conner at KRAS Kickers.
Hi, I'm Dr. Jack West. I'm a medical oncologist focused in thoracic oncology, associate professor at the City of Hope Cancer Center in the Los Angeles area. I'm very happy to be joining you today to talk about these timely topics, actual controversies, open questions in lung cancer at the end of 2022, entering into early 2023, because we got some new data over the last year, but along with answers, we certainly have some ongoing controversies and open questions. I'm going to focus on 5 today. The first is a lot of new information on early stage non-small cell resectable disease, but some lingering questions about molecular testing, what is best, and what is the optimal timing of delivery of the perioperative therapy options that we have. We have an update on ADAURA. So the question with adjuvant osimertinib is, should we be as enthusiastic and committed to osimertinib if with new data we're seeing that the benefit in terms of DFS at least appears to erode after 3 years? Third, based on the EMPOWER-010 trial, we got some overall survival data, and it looks like the benefit appears to be driven by, if not completely limited to, patients with high PD-L1. Should we be pursuing this broadly? The FDA approval is for patients with any PD-L1 of 1% or higher, but should we really be focusing on just a subgroup? 4, as a broad concept, really looking at patients with driver mutations or low negative PD-L1, should we be deselecting patients from trials in which they are technically eligible, they are reasonable candidates, they were part of trials that were positive, but they were subgroups that did not achieve a benefit, and they may even achieve harm. So we'll talk about that, and then look at the optimal duration of therapy and whether maintenance immunotherapy in the setting of advanced disease for patients who are still responding well should discontinue therapy at 2 years or some period of time. Let's move on. So turning to open questions on early stage non-small cell testing and timing, specifically molecular testing. We've known about EMPOWER-010 for years, an important study that has led to an FDA approval and really evolving practice change in this early stage setting around the world. I'll just remind folks that this did not have any required or routinely done mutation testing in this particular study. So patients with EGFR and ALK rearrangements were allowed in this study. They were included, and we got a little bit of subset information on them. In contrast, for patients in Checkmate 816, patients with an EGFR or ALK mutations were excluded from this study if it was identified. On the other hand, really questions about whether optimal treatment for patients with RET or MET or some of these other known driver mutations should be excluded as well. And then in Keynote-091, similar to EMPOWER-010, this was a study of placebo or pembrolizumab in the postoperative setting, and there were no restrictions based on mutation status. So there's arguments to be made for broad testing. There's arguments to be made for much more narrower testing. The arguments I would say for broad testing is that we know that it's not just EGFR and ALK that these patients seem to benefit little or none from immunotherapy. It's important to not paint all driver mutations with the same brush, because patients with KRAS mutations or BRAF appear to benefit comparably to patients with wild type. But for most of the others, there is somewhat between little or no benefit, such as with ALK positive disease. Most of those patients get remarkably little benefit from immunotherapy, so we don't necessarily want to pursue a year of added immunotherapy with attendant risk. If patients are unlikely to benefit, we also may want to direct these patients to the systemic therapy approach that we would consider to be optimal for them based on the studies in advanced disease. We might generalize from ADAURA and say that ALK inhibitors or selpercatinib would be appropriate depending on the driver mutation if you find an ALK rearrangement or RET fusion respectively. Ideally, if there's a trial, that's certainly the perfect way to do this, but sometimes it's might be a consideration even outside of a trial. I would also say that it's important perhaps to know that someone has a driver mutation, not just because immunotherapy may be not helpful, but because a transition straight from immunotherapy to a tyrosine kinase inhibitor in the event of progression could be associated with toxicity issues. We certainly see this with osimertinib, and going from a checkpoint inhibitor to osimertinib associated with potentially life-threatening or fatal pneumonitis, and other toxicities can occur with other tyrosine kinase inhibitors, even if it's sequential, because immunotherapy lingers with a long half-life of weeks. And so it's in your body for months after that. But we also need to recognize that broad molecular testing incurs much greater cost than just checking for EGFR or ALK discretely. And time is an issue. This is something that takes weeks to get. On the other hand, so let's look at EGFR and ALK. This is what was included in the CheckMate 816 trial. And as I mentioned, this wasn't even included at all in the other studies. You get a faster turnaround and can move on with your plan, lower cost, and you avoid the uncertainties of perhaps getting a RET fusion back and then having to scratch your head, have difficult conversations with the patient, but not really know or have evidence to guide what to do in this situation. My interpretation in this ambiguous setting is that I would generally favor broader NGS testing in patients who are clearly candidates for and have high enough risk of relapse that we would routinely pursue systemic therapy. So not for a patient with stage 1A disease. I wouldn't have much enthusiasm for broad molecular testing. It adds cost, and you can't unknow what you know. And I think it's really questionable to do this for someone with a 2.4 centimeter solitary node negative cancer. But if a patient has stage 2 or 3 disease, arguably stage 1B, and you're inclined to give systemic therapy, you'd really like to know what the optimal one is. These are patients who are all candidates for chemotherapy, and I would pursue that. But I think it's valuable to not just know about EGFR and ALK, but to be informed about whether a patient's cancer harbors a RET fusion, MET exon 14, et cetera. It is important to recognize these may or may not be covered. It's important to be aware of the turnaround time and question whether it's feasible for a particular patient. I would mention as well, though, that if timing of the turnaround time is a real issue, it can be feasible to just start with the chemotherapy for the first cycle in the preoperative setting, and then add in the nivolumab following CheckMate 816 for 3 cycles once you get the NGS panel back. So if a patient's very anxious, or you feel a patient really should start systemic therapy without weeks delay, you can do that and just deliver 4 cycles of chemo and the last 3 with nivolumab. I think that's perfectly great. It's important also to recognize that doing lesser testing here is not a wrong choice. I just would favor it less. Let's turn to the question of optimal timing. And I think we should acknowledge that we've got preoperative options, we've got postoperative options. I prefer neoadjuvant for a few reasons. One, the CheckMate 816 approach is just 9 weeks of therapy. Even if you had a 4-cycle, you're talking about 3 months of therapy, and then your surgery, and then you're potentially, if not typically, done at that point, and a patient can move on with their life, recover, and not pursue any other therapy. So I think that's a big benefit compared to going to surgery, then doing 3 months of chemotherapy, and then a full year of immunotherapy after that. That's a long period of patients pursuing therapy and being tethered to the infusion chair. Then there's the issue of preoperative therapy actually just being delivered as intended far more often than postoperative therapy. And we really need to acknowledge in the real world studies over the last few years that only maybe 40–50% of patients who are appropriate candidates for postoperative therapy, at least in the US, are getting that. And in the NATCH trial, I highlight that in the middle portion here, Enriqueta Philippe and colleagues, it's over a decade old, and it looked at preoperative versus postoperative carbo and paclitaxel, a generally very reasonably well-tolerated regimen, was delivered as intended over 90% of the time preoperatively, but less than 2/3 of the time, only about 60% in the postoperative setting. So a lot of things can happen on the way to postoperative therapy, and the most reliable way to get multidisciplinary treatment is to use this sequence. And then on the right, I would say, as I highlight in those panels, you get the feedback of preoperative therapy, both immunotherapy and path-CR rate, the degree of viable residual disease, I think is extremely valuable to get prognostic information and potentially customize postoperative therapy. You're not treating blind as you would be in the postoperative setting. So it's certainly reasonable to do postoperative therapy. That is an option, but I would generally prefer the neoadjuvant approach. Let's turn to the question of adjuvant osimertinib and what we've learned from updates on the ADAURA trial. So we did get an update from Dr. Suboy and colleagues at ESMO in the fall, looking at ADAURA with 2 more years of follow-up that included all of these patients completing their 3 years of intended oral therapy, which was either osimertinib or placebo. And as shown in both of these curves, but definitely more pronounced in the higher stage 2 and 3A disease, at the end of 36 months, you see this drop-off in disease-free survival. It's really quite striking for stage 2 and 3A. And we don't have any update on overall survival. The DFS benefit is still present, but it is clearly very time-limited to while patients are on treatment. And it really looks like a lot of patients, maybe most or all, are not having their disease eradicated from even an extended period of osimertinib. And the same can be said for CNS relapse rate. It's not as dramatic. Obviously, not as many patients are going to relapse with disease in the brain, but you see this drop off at 36 months. And it really suggests that this is not curing disease. And I think it's going to lead to questions of whether patients should continue beyond 3 years. It's also fair to question whether, if you're not curing these patients, adjuvant osimertinib is worth it, so to speak. I would say this remains a judgment, but I would say, even though I don't love many aspects of how this trial was done, I wish overall survival were the primary endpoint, but we need to operate within the confines of what we know at the time. I would say that it is extremely likely that even if these patients are not all cured or mostly cured, it is likely that this will lead to a survival benefit. And I think it is appropriate to at least consider whether it is feasible and appropriate to treat beyond 3 years if you get this ongoing benefit while patients are on treatment, but not beyond that. I think it's important to factor in the consideration that what do we do in advanced disease when we know someone has EGFR mutation positive disease? We treat with osimertinib until progression. And it's not with an expectation that we're curing patients, but we are very, very happy to treat on an ongoing basis for years potentially to have that translate to an improvement in overall survival, even if not cure. And I think this is, to me, a very similar situation. Let's turn to adjuvant atezolizumab. This approach is FDA approved based on Empower 010, which included a broad range of patients, but the benefit in terms of DFS was definitely stronger in patients with PD-L1 positive disease, and especially high PD-L1. What we saw this year with an update at World Lung in Vienna was evidence that the overall survival was just on the border of significant benefit in the broader population of 1% or higher PD-L1. Here you could see it. It's not quite positive if you included EGFR and ALK positive. If those patients are excluded, it barely meets those criteria at the bottom left. But in what I've highlighted in red here, you can see that the benefit is overwhelmingly concentrated in patients with PD-L1 expression of 50% or higher, where the hazard ratio is about 0.43. It's essentially 1 in patients with PD-L1 of 1 to 49. And so while we have an approval that allows this, I am not that inclined to favor it in patients with low PD-L1 for several reasons. You just don't see a benefit at all in patients with low PD-L1. And this is a treatment that adds a full year of ongoing IV therapy. You can have toxicities that are permanent. Patients may develop endocrinopathies, diabetes, et cetera, that, or even rarer significant toxicities that can be quite serious and permanent, not to mention the large cost of this. I feel it is far more appropriate to pursue this in patients in the subgroup who did not previously, the subgroup with PD-L1 of 50% or higher. In those with 1 to 49%, I would say the risk exceeds the benefit in the vast majority. It is still always appropriate to individualize to the patient in the exam room with you. If you have someone with extremely high risk disease, sure, maybe, but that would not be my general approach. In my mind, I would say this is the least controversial and open question of these controversies. Next, a question of whether patients with driver mutations, maybe even selecting based on PD-L1 less than 1%, should be deselected from standards of care for which they are eligible. It's really the same question I was just asking, but you can look at it in different settings. Now, we have patients with EGFR mutations, sometimes ALK, analyzed in subgroups on Empower 010 and PEARLS. And you can see mixed results, different results in Empower 010, where there was really no evidence of a benefit in EGFR mutation positive or ALK rearranged disease with atezolizumab. On the other hand, with Pembro, EGFR mutation positive, as shown on the right, was associated with a benefit from pembrolizumab for whatever reason. It's a subgroup analysis. It's not definitive, but hard to say. And again, these patients would potentially be eligible. I think it's worth also looking at results from Jarushka Naidoo's analysis presented at ASCO in 2022 of EGFR mutation positive patients on Pacific who got no benefit by progression-free survival or overall survival with durvalumab. And again, this is something associated with toxicity, cost, and certainly the added rigor of a year of therapy. I'll underscored, kind of like we were looking at for adjuvant atezolizumab, that in patients with PD-L1 less than 1%, this is Luis Pazara's publication from a couple of years ago from Pacific. This is probably no surprise to the physicians in Europe, where durva is not approved in the less than 1% subgroup. There doesn't appear to be a benefit. And I think many of us in the US are at least asking the question, if not disinclined to favor giving durvalumab for these patients who don't clearly benefit, or it's at best an open question. And then again, if we look at and find a driver mutation such as MET or RET, it's ROS1, these are patients who tend to get little, if any, benefit from immunotherapy and may have significant toxicities. This year, we should expect to see results, I hope, from the Lawler trial of consolidation osimertinib, which I strongly suspect is going to look remarkably more effective for EGFR mutation positive disease than durvalumab consideration. So these, however, were patients who were eligible for the study. In favor of treating, the trials were positive, they were eligible, they're part of the analysis. And some would argue that if a treatment is approved as a standard of care and may offer a benefit, we should offer or even recommend it to all of these patients. On the other hand, the actual data that we have, if we look in a more granular way, suggests these are not patients who are likely to benefit. And there may be toxicity risk, particularly in the patients with a driver mutation who may need to transition to a TKI and run into these toxicity issues with certainly concurrent, but even rapidly sequential approach. It's not a relevant issue for those who are PD-L1 negative, but wild type, and you're thinking about excluding durvalumab. My own views on this is that I have become disinclined to favor this. I would talk about it with every patient, and this is, in my mind, an area of shared decision-making with the patient. Interestingly, I've heard of a lawsuit in the US where a patient with an EGFR mutation did not get, and I don't believe was offered, durvalumab for stage 3 disease after chemoradiation, developed relapse and sued because he did not get the durvalumab that was considered standard of care, even though many thoracic experts would consider that the right approach. To me, this just underscores that it is appropriate to not pursue this for many patients, but I would prefer to not make that decision unilaterally, but to express my rationale for why I would disfavor it in some patients. And then, should maintenance immunotherapy in advanced disease stop after a fixed period? It's worth noting that the typically 2-year interval of treatment until stopping in patients who haven't had progression and are tolerating it well is just an empiric choice and an empiric decision. This was what was in the studies, and therefore we follow it. That doesn't mean that it's the best approach. We got data a few years ago from the Checkmate 153 trial that suggested that longer treatment is better. This is with a distinct clinical population we really don't see that much of anymore. This is patients who got nivolumab as second line. These are not selected patients with a high probability of benefit from immunotherapy. And they did get a clear improvement in progression-free survival and overall survival if they continued beyond 1 year and they hadn't progressed at that point. But this was really limited to the patients who had experienced a response. It was not seen in patients who had achieved just stable disease or some progression but continued on treatment. So I think you can only take this so far, particularly because this is just not the way we're using immunotherapy today. When we look at the 5-year outcomes from Keynote-024, you can see that on the left, 46% of patients were alive without progression or subsequent therapy at 5 years out, and that's from 39 patients who completed the full 2 years and then stopped. Some patients had relapse and 12 were retreated. We saw responses in about half of them, but that is not, to me, as favorable as maybe I would hope to get. And so I think this is a question of half empty, half full. We can also look at the data with chemo and pembro. We got results from 5-year outcomes from Keynote 189 with chemo pembro, and that's maintenance after cisplatin, and pembro with cisplatin and pemetrexed. And then Keynote 407 with maintenance pembrolizumab after carbo and a taxane for squamous lung cancer. These all show very similar results of about 40 to 45% of patients out that far without progression or death. And they had stopped at 2 years. I would say that, again, is this a strong support for stopping? We know it's possible that patients will do very well, but less than half of patients without evidence of disease, I just wonder if we could do better if patients continue beyond 2 years. We don't have comparative data. My own predilection is I suspect that there would be a greater benefit if patients who are doing well continue on treatment. We absolutely don't know. I think it's a setting for judgment, and it's important to consider how a patient is tolerating it, what is economically feasible and where you are. But I think it is something to really individualize based on your healthcare setting and the patient in the room with you. I would note that patients can respond to rechallenge, but the results are not tremendous. Many patients don't respond. And so I would probably be more inclined to favor it in patients who are tolerating treatment well. So to just recap, looking at these 5 questions, for patients in the perioperative setting, I favor NGS testing if feasible. I do favor neoadjuvant over adjuvant, all else being equal. Is adjuvant osimertinib good enough if the benefit erodes after 3 years in patients who would be candidates for ADAURA? In my opinion, I think yes. I would say that it is not a wonderful value proposition. We don't know about overall survival yet. I suspect it will be associated with a survival benefit. I think it would be helpful to look at ctDNA to help inform our decisions, but we don't have that yet. And we can only operate with what we know at the time. Should adjuvant atezolizumab be limited to patients with high tumor PD-L1? This is a setting where I think it's an open question. We have an FDA approval, but I really would say for patients with PD-L1 in the 1 to 49% range, there is no evidence of a benefit. And we know it adds time to a year of treatment, cost, potential toxicity. 4, should patients with driver mutations be deselected from standards of care like immunotherapy? If they'd be eligible, I think it's appropriate to individualize, but I lean towards being judicious about this and generally would recommend against immunotherapy when the majority of the evidence suggests that these are not beneficiaries. And then the duration of therapy for patients who are doing really well on pembrolizumab or other immunotherapy at 2 years or beyond. I think there is room to individualize for the patient. It's certainly very appropriate to just follow what was done in the trials and stop. But I personally would favor for a motivated patient if it's feasible and they're not having adverse events. Thank you so much for your interest, and I'm happy to have people contact me via Twitter or other mechanisms if you have comments, questions, want to debate some of this. Thanks so much. Take care.
Good afternoon. My name is Jarushka Naidoo, and I'm a professor of medical oncology and consultant medical oncologist at the Beaumont RCSI Cancer Centre in Dublin, Ireland. Thank you to the OncoAlert team for the opportunity to present in this year's colloquium on small cell lung cancer. These are my disclosures. For the purposes of today's talk, we'll give a little brief background on small cell lung cancer, followed by some recent updates on extensive stage small cell lung cancer, followed by limited stage disease, and then notable future directions focusing on new agents and biologic breakthroughs for this difficult to treat cancer. So by way of background, we know that small cell lung cancer is the less common of the thoracic malignancies, accounting for approximately 13% of new lung cancer diagnoses, and has a strong association with smoking. This is a systemic disease for which we can use the classic TNM staging or the modified VA lung cancer group staging, which separates patients into limited stage disease, defined as that disease which is confined to one radiation portal, or extensive stage disease, which accounts for about 70% of cases. We know that patients with small cell lung cancer have transient responses to cytotoxic chemotherapy, and that overall the prognosis has been poor. This is a timeline of the evolution of systemic therapies that have been used for small cell lung cancer starting in the 1960s, where we principally used best supportive care and some basic chemotherapy with agents such as cyclophosphamide. In the early 80s, we started to use combination chemotherapies with agents such as CAV, and then in the 1990s ushered in the era of platinum doublet chemotherapy. Just in the last number of years, we've started to use immunotherapy with immune checkpoint inhibitors for patients with small cell lung cancer. And in recent years, understanding a little bit more of the biology of this disease and some of the immunotherapeutic approaches now moving into clinical trials for limited stage disease. So to recap the story of immunotherapy in small cell lung cancer, this had a somewhat checkered past. So we see here in 2016, to start off with, that single-agent immunotherapy with either nivolumab or pembrolizumab was initially made available by the FDA for the treatment of pretreated small cell lung cancer, based on some early phase studies with response rates ranging from around 12 to 33%. And we see here from the swimmer's plot of the single-agent pembrolizumab studies and other studies that a small but real group of patients with small cell lung cancer did appear to be deriving prolonged benefit from these agents. However, subsequent studies did not confirm these responses and resulted in withdrawal of single-agent immunotherapy in the pretreated setting in 2020 and 2021. An example of this, of course, the CheckMate 032 study, in which ipilimumab and nivolumab was trialed, and we see here response rate relatively modest of 19 to 23% for the combinations and just 10% for single-agent immunotherapy. Subsequent second-line and even maintenance studies of the combination not revealing an overall survival benefit. However, as we see here in the red circle, still, there was a glimmer of hope with this tail on the curve phenomenon that we do see with immunotherapy, where at 2 years, the overall survival of patients who received immunotherapy was around 25%, and more impressive than those who received single-agent immunotherapy at around 14%, and thus ushering in our studies in the first-line setting. This is a summary of some of the first-line combination studies incorporating immunotherapy with standard platinum doublet chemotherapy in the frontline setting. The two seminal clinical trials that ushered in these combinations as are now standard of care first-line options include IMpower 133, in which atezolizumab was combined with platinum doublet chemotherapy, or durvalumab in the Caspian study. Both of these studies had demonstrated a small but significant benefit in overall survival, with a proportion of patients living longer at both 1 year and 2 years. And we see a number of other studies using other anti-PD-1 agents, such as serplulimab with the ASTRO 005 study, the Capstone 1 study, and EA5161, demonstrating these continued overall survival benefits with single-agent PD-1. To recap, the two studies that change the standard of care include IMpower 133, for which we have 2-year overall survival data published in the JCO in 2021. To recap the scheme of the study, 402 patients are randomized 1-to-1, comparing platinum doublet chemotherapy with carboplatin etoposide together with atezolizumab that would then be continued till progression or unacceptable toxicity. We see here the Kaplan-Meier curves that separate, demonstrating a 2-month benefit in overall survival and a hazard ratio of 0.76 that was statistically significant. We see here that this was quite a well-tolerated regimen, with only 4% of patients coming off therapy as a result of adverse events. More mature data here, 3-year overall survival data for the Caspian combination, durvalumab plus platinum etoposide here, demonstrating a benefit in overall survival, again, of around 2 months, hazard ratio of 0.71, and grade 3 adverse events of 32% versus 36%. And again here, that impressive tail on the curve phenomenon, with 17.5% of patients alive at 3 years compared to just 5.8% of patients receiving chemotherapy. This study also examined the role of durvalumab and tremelimumab compared with platinum doublet chemotherapy. But what we saw here was there was no significant benefit in overall survival for this combination, and therefore this is not a standard of care. Ongoing debate with the use of chemoimmunotherapy in small cell lung cancer is whether we can identify predictive biomarkers to help inform treatment selection. Unfortunately, the story for PD-L1 and TMB in small cell lung cancer does not recapitulate that of non-small cell lung cancer. Here we see the biomarker-driven subset analyses of both IMpower133 and Caspian, identifying whether PD-L1 or TMB may be predictive biomarkers of response to these agents. And broadly, what this shows is that patients may respond to either the IMpower133 or the Caspian regimen, regardless of PD-L1 expression or TMB status. Therefore, these are not used as predictive biomarkers for selection of any of these therapies, or even as negative predictors. Moving on to the second-line setting, lurbinectedin. This is a special marine-derived agent that has been studied in the relapse setting for small cell lung cancer. The dose of 3.2 milligrams per meter squared every 3 weeks was evaluated in a large study of more than 105 patients and demonstrated a response rate of 35.2% and a median duration of response of 5.3 months. Impressively, in this study, we saw responses in patients with both platinum-sensitive and platinum-resistant small cell lung cancer, with a median overall survival of 9.3 months. Based on these data, published in the Lancet Oncology in 2020, lurbinectedin monotherapy received FDA accelerated approval in June 2020. However, full approval is contingent on a confirmatory phase 3 trial. The combination of lurbinectedin and doxorubicin was also evaluated in a large 17-center study in 631 patients. This study was somewhat criticized for the modified dose of lurbinectedin of 2 milligrams per meter squared when combined with doxorubicin, which may have contributed to, as we see here, completely superimposable curves for progression-free survival with a hazard ratio of 0.97 and no overall survival benefit. Therefore, this combination, while studied in a large prospective study and compared to accepted standards of care, has not moved the needle in this setting. The ongoing phase 3 confirmatory study of lurbinectedin monotherapy is ongoing in the form of the phase 3 Lagoon study. This is a 3-arm study in which lurbinectedin monotherapy is being compared to irinotecan, topotecan, and the combination of lurbinectedin and irinotecan. Lurbi is also being studied in the phase 3 IMforte trial, in which the IMpower133 regimen is used as induction, and the role of maintenance lurbinectedin is being evaluated together with atezolizumab compared with atezolizumab alone. Unfortunately, the last year hasn't been all good news stories for small cell lung cancer, and one story that really was an unfortunate outcome from last year's ASCO were the results of the Skyscraper-2 study, in which the anti-TIGIT monoclonal antibody tiragolumab was evaluated combined with the IMpower33 regimen compared to IMpower133 as the backbone. This study was presented at ASCO last year by Charlie Rudin and colleagues, and the primary endpoint of the study was, overall survival and investigator-assessed progression-free survival with a median follow-up of 14.3 months. Unfortunately, again, superimposable curves for both progression-free survival and interim overall survival, with hazard ratios of 1.11 and 1.04 respectively. 117 patients receiving the investigational arm and 116 patients receiving the placebo arm. So we may continue to clutch at the TIGIT straws with other TIGIT-based molecules still in clinical development, but obviously this first inkling of TIGIT and small cell lung cancer not giving us a lot of hope in this area. But of course, never fear, a number of combination strategies are being explored for their utility in small cell lung cancer, including combinations with chemotherapy, TKIs, PARP inhibitors, and other combinations that have demonstrated some preclinical evidence of response. One combination or mode of treatment that I think is worth watching is PARP inhibition. We have seen in preclinical models that PARP inhibition sensitizes to immunotherapy, or the combination of PARP inhibitor and immunotherapy appears to synergize in small cell lung cancer. And similarly, PARP inhibition with temozolomide appears to synergize in the relapse setting, with prospective data published some years ago by Kathy Pietanza and colleagues demonstrating that this combination has some activity, and that SLFN11, a DNA RNA helicase, may be a biomarker of response to DNA damaging agents in this subset of patients. We see here PARP inhibitors also coming to the fore earlier in patients' treatment course. This is an example of a maintenance study in which patients will receive atezolizumab with the DNA damaging agent talazoparib compared to atezolizumab in SLFN11 positive disease. Combinations also assessing the combination of immunotherapy and PARP inhibition, as well as radiation and PARP inhibition in patients with small cell lung cancer. So certainly watch this space. Another group of agents or type of agent that has demonstrated some activity in this disease is a bispecific T-cell engager molecule targeting DLL3 and CD3 called tarlatamab. We see here a schema of how this agent works mechanistically, and has been explored now in a larger study of 106 patients with an objective response rate of 23% and disease control rate of 52% in the third-line setting in small cell lung cancer. Importantly, the side effect profile of these agents should give us pause around just over 53% of patients having cytokine release syndrome as a result of this agent, only one grade 3 event, thankfully, and overall only 4% of patients discontinuing therapy due to adverse events, but certainly an agent to watch. Moving on into limited stage disease, we see that immunotherapy is now moving into this section of the small cell lung cancer treatment paradigm. This is an example of several studies in which immunotherapy is being explored as a consolidation approach after standard chemoradiation for limited stage disease. Of these studies, the only study to have read out so far is the Stimuli study. This prospective study randomized patients with limited stage small cell lung cancer who sustained a response with stable disease to platinum doublet therapy and chemoradiation, as well as PCI, to either ipi-nivo followed by nivo maintenance or observation. This was a 1-to-1 randomized phase 2 study, but unfortunately patient recruitment was slow, and this study was closed early to accrual. However, the statistical plan was amended to assess progression-free survival as the primary endpoint. And overall, 153 patients were randomized, and there was a median follow-up of 22.4 months. Unfortunately, the median progression-free survival and median overall survival did not demonstrate any statistically significant differences. And some of this outcome may be attributed to the fact that the median time on treatment was only 1.7 months, and the incidence of high-grade toxicity was considerable at 62% for the combination compared to just 27% for observation. Another set of strategies that's being evaluated in limited stage small cell lung cancer is where the immunotherapy can be combined together with chemoradiation, followed by immunotherapy in the consolidation phase. And this is being examined in a number of studies, including a prospective trial being run by the RTOG NRG ALU-005. Two major areas of progress in small cell lung cancer, I think, are the new agents in clinical development and the advances in molecular profiling. And we see here from Roman Thomas's group a publication by Julie George in Nature some years ago identifying the first comprehensive genomic analysis in 110 patients with small cell lung cancer. In this analysis, it is seen that T53 and RB loss is almost universal in patients with small cell lung cancer and may occur by several mechanisms. There are also some identifiable loss of function mutations in multiple epigenetic regulators, including Notch and the SOX family. and about 20% of patients have MYC amplification. Biologically, some important work has also been done in terms of transcriptional subtypes of small cell lung cancer. And herein we see some impressive work from the MD Anderson group, in which 4 specific transcriptional subtypes of small cell lung cancer have been identified, including the ASCL1 subtype, NeuroD1, PAR2F3, and YAP1. YAP1 also being called the triple negative subtype, or SCLCI, that may be responsive to immunotherapy. And we see here in a subgroup analysis of IMpower 133 for overall survival that patients with this I subtype appear to enrich for response and improved overall survival based on these transcriptional subtypes. However, we may not necessarily be ready for prime time with these subsets to inform treatment selection. We see here a further analysis aiming to identify whether these transcriptional subtypes may identify those who are long-term responders to the IMpower 133 regimen. This analysis of gene expression data from IMpower 133 was presented by Stephen Liu at an ESMO virtual plenary session, and here identifies, as we see highlighted in the red box, that patients with small cell lung cancer I subtype may indeed be enriched for response in those who received atezolizumab. However, those who did not receive atezolizumab still appeared to derive some benefit with this subtype. So really, long-term survivors seen in all transcriptional subtypes, and more work needing to be done to see how transcriptional subsets may inform treatment selection. Therefore, in summary, extensive stage small cell lung cancer now has a first-line standard of care of chemoimmunotherapy based on the IMpower 133 trial and the Caspian trial, establishing that either atezolizumab or durvalumab may be added to platinum doublet chemotherapy. Unfortunately, PD-L1 and tumor mutational burden do not identify responders, and an initial experience of adding TIGIT to upfront chemoimmunotherapy does not appear to be favorable based on Skyscraper 02. However, further anti-TIGIT agents are still in clinical development. We now have the second-line option of lurbinectedin in the US. However, this awaits confirmation in the phase 3 setting with the Lagoon study. Ongoing studies are evaluating the addition of immunotherapy either concurrently or as consolidation alone for limited stage small cell lung cancer. And future directions which should give us hope in small cell lung cancer and include some new data regarding transcriptional subtypes and novel agents such as PARP inhibition and BiTE antibodies such as tarlatamab. With that, thank you very much.
Hi, I am Henning, clinician scientist with an interest in radiation precision medicine. And I am glad here at the OncoAlert Colloquium to have company.
Hi, I'm Amy Wisdom. I'm one of the radiation oncology residents, and I have a particular interest in combining immune therapy with radiation therapy.
All right, welcome, Amy. So we have a number of highlights that we want to cover relevant to radiation oncology in the next 10 minutes or so. You see them here. So let's get right to it. Amy, what's new in stage 3 lung cancer?
So one of the most exciting studies that's been published within the last few years was the update to the Pacific trial. This is in stage 3 non-small cell lung cancer. This is really a practice-changing study in unresectable disease. So patients with stage 3A and 3B disease were treated with concurrent chemoradiation therapy and consolidation durvalumab. And this study showed the continued long-term benefit of durvalumab and an impressive 33% 5-year PFS. And importantly, the benefit was seen across many patient subgroups, and the patterns of failure are still waiting to be seen, but the efficacy of durva does hold over many years. You can also see when we look at which patients benefit most from this treatment, that patients with high PD-L1 expression have greater overall survival, and there's really limited benefit, no clear evidence for benefit in patients with less than 1% PD-L1 expression. Some of the current challenges for this study include the fact that even in high PD-L1 expressing patients, The 5-year survival is only 33% for all comers. We need to work to improve both local control, but of course we know that most of these patients actually fail distantly, and so we need to find a way to improve the high distant metastasis rates as well. We also need to continue to work to reduce radiation toxicity and introduce precision medicine concepts that can help identify which patients might have radiation or chemo-resistant tumors and may need treatment intensification or require treatment with alternative approaches. Another really practice-changing study that's been published within the last year is the Checkmate 816 study. This was looked at patients with stage 1B to 3A disease. Of course, patients with targetable mutations were not included, and patients were randomized to receive either neoadjuvant nivolumab with chemotherapy or chemotherapy alone, and then went on to have surgical resection. You can see that the patients who received the chemo-nivo group had significantly increased rates of path CR, 24% compared to only 2% in the chemo alone group, and an improved event-free survival. Although the majority of this benefit is driven, as you can see, by patients with a high PD-L1 expression, with really low response rates in patients who had less than 1% PD-L1 expression. And here we're comparing some of the recently published studies, the Checkmate study I just mentioned, the Nadim 2 study, and the Pacific study. All of these looked at patients with stage 3A and 2 unresectable, or with 3A and 2 disease, although the patients in the Pacific study were unresectable, and Checkmate and Nadim both looked at resectable disease. So you can't really draw a direct comparison, but you can see that in all of these groups, immune checkpoint therapy does improve survival. Of course, this does leave a number of open questions, right? What's the role of radiation therapy in neoadjuvant treatment for these patients with locally advanced but resectable non-small cell lung cancer? Patients who can't have induction, checkpoint blockade might receive induction with chemoradiation therapy. And we need better studies to identify which patients may actually benefit from receiving induction immune therapy versus radiation therapy. We can't just go ahead and say, every patient will benefit from one or the other. And of course, the role of postoperative radiation therapy is also unclear. The PORT-C and the LUNG-ART trial were both published recently, and they confirmed that postoperative radiation also improves local control. The PORT-C trial in particular showed the LUNG-ART trial in particular showed high toxicity rates, but used kind of outdated radiation therapy modalities. And so to reduce toxicity in these patients, we will need to use highly conformal radiation, such as IMRT. And then, of course, there are different patients that were involved in the neoadjuvant versus the postoperative studies. They differ based on PD-L1 expression, surgical candidacy, and a number of other factors. But what we would advocate is a multidisciplinary evaluation of all patients with resectable stage 3A disease that involves radiation oncology discussion before committing to chemo checkpoint blockade induction. In particular, chemo radiation therapy after induction with checkpoint blockade and chemotherapy alone might have a poor outcome and is really a relatively data-free zone. Henning, you can tell us what's new in stage 4 disease.
Yeah, there are a handful of trials worth highlighting. The first one here is the CURB randomized phase 2 trial out of Memorial Sloan Kettering that was presented by Jillian Tsai at the annual ASTRO meeting this past year. And patients with lung or breast cancer, a total of about 100 patients, were randomized to receiving SBRT or standard of care to all progressive sites. And as you can see here, the majority had progression in more than one site. And patients who received SBRT derived substantial benefit with a 4-fold increase in the time to median progression-free. Sorry, let me correct this, time to progression. So as you can see here, median PFS, SBRT 10 months, and standard of care 2 months, and this was true for lung cancer patients, but not breast cancer. SBRT was really well tolerated with no significant toxicities or serious toxicities are reported, and this is really nice data that support what is current practice already in the treatment of lung cancer. The second trial to highlight is the use of SBRT in patients with oligometastatic EGFR mutant lung cancer. Is the CINDAS trial out of China. Patients were randomized to first generation TKI plus minus SBRT to the primary and all metastatic sites prior to the initiation of TKI. There was an 8-month survival benefit with SBRT. There was some toxicity observed. Now, how do we interpret this trial? It does suggest that there may be a role for radiation therapy in the treatment of these patients. Although in the era of osimertinib, one has to see how this would play out. And SBRT is possibly more appropriate as a consolidation procedure rather than upfront, for example, after maximum response to TKI. So we're looking to other trials coming out in the next 2 years to help us answer this question. Amy, what else do we have in stage 4?
So there are a couple of really exciting studies in stage 4 disease. This study, led by Aaron Gillespie at Memorial Sloan Kettering, looked at prophylactic radiation treatment for patients with metastatic solid tumors with greater than 5 lesions. So patients with at least 5 sites, including one, quote, high-risk site, which means it was, either bulky disease involved the hip, shoulder, or SI joint, was in the long bone, or in a junctional location of the spine. All of these patients were randomized to receive either prophylactic radiation therapy to the high-risk site or no radiation treatment. And you can see that the most common tumor type here was lung cancer, made up 27% of the patients. And interestingly, so they use this outcome called skeletal-related events, which is defined as pathologic fracture, cord compression, or surgery for instability. And compared to standard of care, radiation therapy prophylactically given to asymptomatic high-risk bone metastases reduce these skeletal-related events and reduce subsequent pain and hospitalizations. And really impressively, radiation therapy also had a significant overall survival benefit, increasing the median from 1 to 1.7 years compared to standard of care treatment. Although kind of the mechanism here could involve palliation, symptom management, need for other hospitalization, but really phase 3 studies are needed to further address this. And importantly, when we're giving radiation therapy in the absence of symptoms for palliation, it's important to note that treatment-related toxicity was really uncommon, less than 10% of patients, but there's a less than 10% increase in grade 2 toxicities. So this is really a promising new indication for radiation treatment in non-small cell lung cancer. Of course, there will be further studies to validate this and really optimization and identification of which patients can benefit most from this type of intervention. Another really practice-changing study was this study looking at proton versus photon CSI for leptomeningeal disease. So this looked at patients with breast cancer or non-small cell lung cancer, and patients were treated either with protons for full craniospinal irradiation or with photons for just involved field radiation therapy, because of course photon CSI would be too toxic in these patients. All patients received 30 gray and 10 fractions, and the primary endpoint was actually progression-free survival for CNS disease. And you can see that there's a benefit in terms of CNS progression-free survival, but similar to the last study where kind of palliation improved overall survival, this study also showed an improvement in overall survival without a difference in grade 3 or 4 adverse events. Obviously, some new challenges here might be insurance approval and determining which patients can tolerate this treatment and may benefit, but this is really a provocative study that suggests that possibly CNS control in patients with leptomeningeal disease can lead to improved overall survival. So that was the major changes in stage 4. Henning, what about early stage disease?
Yeah, let's take a look outside into the surgical world. So at World Lung this past year, very exciting, and people were really anticipating this trial, CLGB 140503, and that was a randomized phase 3 trial between sublobar resection, both segmentectomy and wedge resection, versus lobectomy. And important to note that the randomization was done after an intraoperative nodal assessment of hilar and mediastinal lymph nodes. So patients had to be N0. You see the breakdown here. And I don't know, perhaps unexpectedly, at least to me, on the next slide, there was no difference in disease-free survival and overall survival. And you see in the table there, that the disease recurrence pattern were very similar between lobar and sublobar resections, with very similar local regional recurrence, and obviously distal metastasis, as you would expect, were similar. Overall, about 30% recurrence actually for these tumors that were 2 centimeters or less. So together with the previously published JCOG 0802, this does suggest that sublobar resection is the new standard of care for these patients. Why is this relevant for radiation therapy? Well, not quite yet, because radiation is not a standard of care in operable patients, but it does show that sublobar resections, which in a way radiation tries to emulate, is an appropriate approach. And we are waiting for the results of VALOR, which is a randomized phase 3 trial comparing SBRT to surgical resection, but it's going to be a few more years. And then we have also a look, and that's how we wanted to conclude this today, at the world of lung cancer screening, where there is still much room for improvement in the United States. Only 6% or so of eligible Americans are screened for lung cancer, with Massachusetts leading the way. And there's a real benefit here because we do expect stage migration, that patients will be diagnosed at an earlier stage, and that there will be opportunity for early intervention and better curative outcomes. And maybe there's even a role for radiation therapy in this patient population. You see an illustration of what happens when radiation oncologists join a nodule screening and management clinic. Patients that have screening detected lung cancers actually can receive radiation, and that is potentially a good thing to have another treatment options available. So, and I think that concludes it. I'm going to summarize on the next slide. What we talked about today is, number one, we wanted to highlight that high local tumor recurrence rates in stage 3 inoperable disease do remain a major clinical problem, and it is on us radiation oncologists to solve that. In the realm of resectable N2 disease, the footprint of radiation has somewhat diminished, and the future for radiation therapy may be dependent on predictive biomarkers here. We've seen a number of really smart trials to develop a role for radiation therapy in stage 4 lung cancer, as depicted here. And then, as I just mentioned, we should keep an eye on developments in early stage lung cancer and lung cancer screening, where the role of SBRT may become more prominent in the future. And with that, we thank OncoAlert for the invitation. On the next slide, Amy. And to allow radiation oncologists to have a voice in global oncology. We do think this is important, and we thank ASTRO very much for supporting this effort. And I thank you, Amy, for joining me to do this together.
Yeah, thank you.
Dear colleagues, dear friends, welcome to the OncoAlert Colloquium. My name is Giannis Mountzios, and I am a medical oncologist at the Henri Dinan Hospital Center in Athens, Greece. Today, I have the pleasure and the honor to present to you the most recent scientific advances in a challenging disease, which is malignant pleural mesothelioma. These are my disclosures. And this is a brief overview of today's presentation. We will start by providing some basic data on epidemiology and biological background of mesothelioma. We will then summarize the most recent therapeutic advances in the fields of angiogenesis and immunotherapy. We will continue by giving an overview of the most recent scientific advances in year 2022, and we will end the presentations by giving some practical take-home messages. So, as we all know, mesothelioma remains a rare cancer, and this is why we usually refer to it as an orphan tumor. However, it has a high clinical impact globally. There are 3 major pathological histotypes, namely epithelioid, sarcomatoid, and mixed or biphasic, with distinct biological characteristics. Clinically, this is a tumor with a long latency, and it usually affects elderly patients with a median age at diagnosis of 77 years old. And in terms of current treatment options, platinum-based chemotherapy with pemetrexed has been the standard of care for many years with moderate outcomes, modest outcomes, including median overall survival rarely exceeding 1 year and a 5-year overall survival of less than 10%. Therefore, we certainly need to do better in this disease. We all know that exposure to asbestos was and remains the main carcinogenic, the main risk factor for the development of malignant pleural mesothelioma. However, as you can see in the left side map, mining of asbestos still continues in several countries, and there is a huge export for use in developing economies, which is expected to perpetuate the global incidence of exposure, and therefore mesothelioma remains a global health concern. In this busy slide, we can see that unfortunately it was not until 1976 that asbestos was characterized as a carcinogenic, and it was not until several years later that other risk factors like germline BAP1 mutations were identified, and only in 2015 we had the results of the first randomized phase 3 trial that provided overall survival benefit as compared to platinum and pemetrexed. BAP1 protein is a special protein for malignant pleural mesothelioma. We know that it participates in the BRCA1 related pathway of DNA repair mechanism. It has been identified as somatic mutations in approximately 1/5 of tumors, with a prevalence in smokers, higher prevalence in smokers, but it does not harbor a prognostic value. There is also 10 to 20% of patients present with germline BAP1 mutations, and this belongs to a rare hereditary syndrome that also harbors other malignancies like uveal malignant melanoma and renal cell carcinoma. What about the immune phenotype in mesothelioma? We know that mesothelioma has a relatively low mutational load as compared with other malignancies, as you can see in the upper half of the slide. But on the other hand, it is characterized by a high T-cell inflamed microenvironment, as you can see in the lower slide. So immunotherapy is clinically relevant and biologically relevant for mesothelioma targeting. What about PD-L1 expression? Mesothelioma is one of the tumors with modest PD-L1 expression. It is relatively higher in sarcomatoid histotype, but is lower compared to other tumors like non-small cell lung cancer and other tumors of the upper respiratory tract. Moving on to recent therapeutic advances in the treatment of mesothelioma, and first of all, drugs that target angiogenesis. The first significant advance was in 2010 when the MAPS trial was published in Lancet, and we saw for the first time that the addition of the VEGF monoclonal antibody bevacizumab improves overall survival as compared to cisplatin pemetrexed alone, with a median overall survival of 18.8 months and a relatively better efficacy in patients with sarcomatoid or mixed histology. Another large randomized phase 3 trial was the LUME-MESO trial, which evaluated the addition of the VEGFR and FGFR TKI inhibitor nintedanib, which also targets angiogenesis, in the platinum plus pemetrexed combination. Unfortunately, this trial was a negative one, with a median overall survival that was inferior in the experimental arm as compared to the control arm. Moving to the second-line treatment, a significant advance was one of the addition of the VEGFR monoclonal antibody ramucirumab in the second-line treatment of monotherapy with gemcitabine. So the RAMES trial was a randomized phase 2 trial that showed that the combination of gemcitabine plus ramucirumab as a second-line treatment was associated with improved overall survival and progression-free survival as compared to gemcitabine monotherapy, and this offers an additional treatment option. Lurbinectedin is another agent that has been shown to be active in the second-line setting by this Swiss trial, with a median PFS of 4.1 months and a median OS of 11.1 months. What about immunotherapy? This table summarizes the results of the main trials of single-agent immune checkpoint inhibitors in the second or later line, and you can see that monoimmunotherapy in the second-line treatment or beyond is associated with modest clinical outcomes, with responses in approximately 10 to 20% of patients and a median PFS which rarely exceeds 6 months. What about combination immunotherapy in the second-line treatment? We have some single-arm phase 2 trials with the Nivo-Ipi and Durva-Treme combinations, which also confer similar clinical outcomes with responses at the level of 25 to 30% and median overall survival of approximately 1 year. An important scientific advance in the treatment of mesothelioma was this randomized phase 3 trial in the second-line treatment, which compared pembrolizumab to single-agent chemotherapy, either gemcitabine or vinorelbine, as a second-line treatment. This was the ETOP 915 PROMISE Meso trial, and showed that this combination, although it was not associated with an improvement in PFS, it nevertheless had superior objective responses that reached the level of 22% as compared to chemotherapy, which produced responses in only 6%. And this can be clinically relevant for symptomatic patients. Another important randomized phase 3 trial in the second-line setting was the CONFIRM trial, which was published in 2021 and showed that nivolumab monotherapy compared to placebo is associated with significant improvements in both PFS and median overall survival, almost doubling of median overall survival in pre-treated patients with relapsed malignant mesothelioma. And this combination, this monotherapy, nivolumab, is an available treatment option for these patients. Summarizing all these results of phase 1 up to 3 trials in the second-line setting, we can say that we have nivolumab, which has been shown to be superior to placebo, and pembrolizumab, which has not been shown to be superior to single-agent chemotherapy in the second-line treatment and beyond. What about the first-line treatment? The most important scientific advancement in the recent years was the introduction of immunotherapy combinations, specifically immune checkpoint inhibitor combinations in the first-line treatment, with the CheckMate 743 trial evaluating the combination of nivolumab plus ipilimumab as compared to cisplatin or carboplatin chemotherapy with pemetrexed in patients in the first-line setting. We should mention that this trial included both patients with epithelioid and non-epithelioid histology, and also with distinct PD-L1 expression, patients with negative tumors and patients with PD-L1 positive tumors. We know today that this was a trial that showed a statistically significant and clinically meaningful survival benefit with the combination of immunotherapy as compared to chemotherapy. You can see a hazard ratio of 0.74, corresponding to a median overall survival of 18.1 months, so practically 1.5 years. And as we can see in the main subgroup of interests, there was a more pronounced benefit in patients with non-epithelioid histology, hence biphasic and sarcomatoid, which are the patients with a more dismal prognosis. And in the lower two diagrams, we can see that the benefit is restricted to patients with PD-L1 positive tumors, suggesting that PD-L1 is a relative biomarker in the first-line treatment of malignant mesothelioma. In this very nice slide that I have borrowed from Professor Popat, we can see that in terms of progression-free survival, you can see that in progression-free survival, there is an initial crossing of the curves in the first 6 to 8 months, suggesting that progression is not always and necessarily clinically meaningful for the activity and efficacy of checkpoint inhibitors, and some patients that may progress initially can still derive substantial clinical benefit and have an improved overall survival as compared to chemotherapy. And this, of course, poses several questions. Another exploratory analysis that was presented by Professor Peters in ESMO 2021 showed that using a 4-gene inflammatory signature score, this had a robust predictive value in identifying the subset of patients who could benefit from the nivolumab plus ipilimumab combination, but on the other hand, it was not predictive for chemotherapy efficacy. In ESMO 2022, this year, Professor Zalkman presented the 4-year update of the CheckMate 743 trial, which shows a persistent clinical benefit with the double immunotherapy combination with a hazard ratio of 0.73 and a median overall survival of 18.1 months. An exploratory analysis was also presented these years with regards to the soluble mesothelin levels, which has been shown to be a prognostic factor for these patients. So we can see in these diagrams that in both the immunotherapy arm and the chemotherapy arm, mesothelin levels were prognostic for overall survival, with higher levels of mesothelin associated with worse prognosis in both the nivo plus ipi and the chemo arms. Moving to what is new in 2022, we have significant advances in the field of immunotherapy and more specifically in CAR T cells. In 2019, a phase 1 study using lentiviral transduced chimeric antigen receptor modified T cells that recognized mesothelin were presented, including, as you can see, 5 patients with malignant mesothelioma, and showed that the treatment was well tolerated and resulted in expansion of the T cells in the blood of all patients, but showed limited clinical activity. In 2022, however, it was published that new CAR T cells targeting a different epitope of mesothelin molecule, namely the HYPE-218 epitope instead of the SS1, which was used previously, is associated with better preclinical outcomes, and this CAR T cell treatment is now in early stages of clinical development. The University of Zurich used a different approach using another protein which is clinically relevant in mesothelioma, the fibroblast activating protein, and showed that using fibroblast activating protein directed chimeric antigen receptor T cells, they were able to produce objective responses in the phase 1 trial of patients with malignant pleural mesothelioma, and this was associated with expansion of the pertinent T cells in a translational part of the study. Another important and interesting aspect are peptide vaccines. So in 2017, we had for the first time a randomized phase 2 trial that showed that the use of the peptide vaccine galenpepimut S, which is a Wilms tumor 1 targeting tetravalent non-HLA restricted peptide vaccine, was associated with a median PFS of 10.1 months and a very optimal median overall survival of 22.8 months. This year, in 2022, SELAS Life Science Group presented the first results of an ongoing phase 1 study with a combination of the peptide vaccine galenpepimut S combined with nivolumab in 8 patients heavily pretreated with bulky disease, and it showed that the median overall survival from the cessation of the most recent previous therapy was 9.4 months, 10.5 months for patients who received at least 2 doses of the combination, and this is a promising combination that is continued to being evaluated. Another way to target malignant mesothelioma is to deplete mesothelioma cancer cells from arginine. We know that arginine is one of the 20 essential amino acids for protein synthesis and survival of cells, and mesothelioma cells are enriched with arginine. So ADPEC20 is a biological degrader of arginine within tumor cells, and the ATOMIC trial is an ongoing randomized double-blind placebo-controlled phase 2/3 study, which evaluates the efficacy and safety of ADPEC20 versus placebo with cisplatin and pemetrexed as the first-line treatment in patients with malignant pleural mesothelioma of both biphasic and sarcomatoid histology. And recently, in September this year, we had the first press release of the Polaris group, which showed that the trial met its primary endpoint. So the median overall survival with the ADPEC20 was 9.3 months versus 7.7 months. And the hazard ratio was 0.71. And please remember that these are patients with biphasic or sarcomatoid histology, so patients that bear a more dismal prognosis. A very interesting study, and we're awaiting for the presentation, the official presentation of the results. What about the combinations of chemo-IO as first-line treatment? First of all, we had 2 successful phase 2 trials which showed that the addition of the anti-PD-L1 monoclonal antibody durvalumab in the cisplatin plus pemetrexed combination showed promising median overall survival ranging from 18 to 20 months. So right now we have several phase 3 clinical trials ongoing. The DREAM-3R trial evaluating the same combination, the addition of durvalumab to the cisplatin plus pemetrexed, and also the BEAT-MESO trial, which evaluates the addition of atezolizumab plus or with or without bevacizumab to the carboplatin plus pemetrexed combination, and the results of these trials are awaited approximately in 2024. Finally, we are starting evaluating adjuvant immunotherapy in patients with resected malignant pleural mesothelioma, and here you have the examples of the atezolizumab trial and the nivolumab trial, the NICITA phase 2 trial, which evaluates the addition of nivolumab after the completion of platinum-based chemotherapy in patients with resected malignant pleural mesothelioma. Finally, precision oncology has entered the mesothelioma arena. I provide you here the example of the MIST platform, the MIST study design. So MIST is a multi-arm phase 2 platform that evaluates the efficacy and safety of several targeted agents associated with specific genetic alterations. So after an extensive molecular and phenotypical screening of the tumors, patients are treated with a corresponding targeted agent associated with the existing genetic alterations. And you can see, for example, that in patients with BAP1 or BRCA1 deficient tumors, a PARP inhibitor is administered, or in patients with P16 INK4A deficient mesothelioma, a CDK4/6 inhibitor is administered. And we have already the first results. Into 2021, the results of the PARP inhibitor rucaparib were reported in patients with BRCA1 and BAP1 deficient tumors, showing promising efficacy. And also this year we had the results of the phase 1 trial for the subgroup of patients with P16 deficient malignant mesothelioma with the CDK4/6 inhibitor abemaciclib, showing a promising response rate of 12% in heavily pretreated patients. So to conclude, I believe it is clear that malignant pleural mesothelioma is not anymore an orphan tumor. It started coming out from the orphan tumor status. Platinum-based chemotherapy remains the cornerstone of treatment for patients with PD-L1 negative tumors. However, in patients with PD-L1 positive tumors, double checkpoint immunotherapy with nivolumab and ipilimumab has become the new standard of care, and especially in patients with sarcomatous and mixed histology. Immunotherapy is, of course, currently being evaluated in the early disease setting, as I showed previously, and novel immunotherapy strategies, including CAR T cells and cancer peptides, cancer vaccines, targeting diverse epitopes, are currently being explored therapeutically in malignant pleural mesothelioma, and we will hopefully have more important scientific advances in 2023. And with that, I would like to thank you for your attention, and I wish to all of you a happy and prosperous 2023. Thank you very much.
Hello, everybody. Delighted to be here at the OncoAlert Colloquium for this year, and really interested in presenting to you some of the work that we're doing specifically in relation to inequalities in Europe in both cancer research and cancer care, and introducing a new platform that we've developed called the European Cancer Pulse. European Cancer Pulse has really been designed to track inequalities across Europe in cancer. It features more than 120 different data measurements. And really it allows us to look at both cancer care activities, but also most importantly, their disparities in 34 European countries, which is the data that we have in the Pulse to date. And this is both across the EU and obviously outside the EU and Europe as well. It's very much a work in progress. The tool will continue to evolve, and we will be uploading more data on the site as we receive it and verify it. And so we will encourage you to visit the site often to learn about cancer inequalities through the European Cancer Pulse. And really what we're looking at here is developing data intelligence, allowing that to provide us insights, and then using those insights to develop new policies or adapt existing policies. So it's very much a policy tool that looks at what are the inequalities, so what's the data intelligence that we can gather, and then how we can use that data intelligence to influence at the European and also at the national level. Unfortunately, it's quite clear that large inequalities exist across the cancer continuum, both within and between countries, and also across different social groups in Europe. And we've seen this right back to when we originally started looking in this area over a decade ago now, with the European Cancer Patient Bill of Rights. To quantify these inequalities, which is really important to understand, and it's great to see that the European Commission has launched the Cancer Inequalities Registry. And this is bringing together comparable data from the EU27 and from official registration sources, which are focused on cancer burden and cancer prevention and cancer detection specifically. It's really important as well that the European Beating Cancer Plan, which we're all very delighted is now starting really to move and gain momentum, includes a focus on the resolution of cancer inequalities, because this is really important. However, there are challenges. And there are certain gaps in the Cancer Inequalities Registry, including in respect to cancer treatment, workforce, survivorship, and quality of life. We really very much see this as a partnership with the Cancer Inequalities Registry, and that the European Cancer Pulse will provide additional information to complement the great data that's already being collected through the Cancer Inequalities Registry. And it's really clear as we sort of develop the Europe's Beating Cancer Plan we're seeing that there are knowledge gaps both within and between different European countries, and this is really becoming apparent. And so we need to develop ways in which we can capture the data intelligence that will allow us to inform both cancer research and cancer care policy. And one of the really important things is the timeliness of the data. It's no use having data that's a number of years old. We really need timely data that allows us to make appropriate public policy decision-making and ensure that optimal cancer control is delivered right across Europe to every country, to every European citizen. Unfortunately, we're not in a situation at the moment where we have enough timely data to make some of those crucial decisions. And this is creating a potential disconnect across Europe in relation to how we collect data, that data, what it tells us, and how we use that in relation to cancer policy. The current data on cancer inequalities is scarce and also maybe scattered in very many different places. So one of the aims of the European Cancer Pulse is to bring together a lot of this data, allow us, really to track inequalities in cancer, and then using that information to inform a data-driven cancer policy agenda. The European Cancer Pulse then is really a data visualization tool, but it has certain innovations. It's very interactive, so it allows you to look in the European Cancer Pulse to see what are the data that are there. It allows us to track inequalities in cancer and also look to ways in which we can resolve these inequalities right across Europe. It captures and gathers multi-stakeholder data, also multidisciplinary data in one place. So that makes it very easy for anybody to access this data and look to see what's happening in their own particular country, what's happening in particular diseases, what's happening in relation to cancer detection, what's happening in relation to cancer treatment, etc. It also allows us to highlight current gaps in research on cancer in Europe, and allows us then to make policy decisions as to where we invest in relation to cancer research. At the moment, we have 34 different countries, both within the EU and beyond the EU, within Europe, who are participating in this in relation to having data from their countries involved in the European Cancer Pulse. As I said already, we have 120 different data measurements and also 20 inequalities categories. So as you can see, even already as we develop the European Cancer Pulse, it's getting really important that we can use this data in an appropriate way, and certainly being comprehensive in terms of our coverage across Europe. It's really important to us and complementing the European Cancer Inequalities Registry. So it includes inequalities on all areas of the cancer pathway, so not just the 4 pillars of the Europe Speeding Cancer Plan. Also, we feel that social determinants of inequalities are really important and how they affect cancer care, so we're collecting data from that. The sources of data from official European sources, from the registry, from the European Cancer Information System. Also from previous research that's been provided by some of our project supporters. You can see on the right-hand side there some of the categories that we're capturing in relation to the data that's been generated and being captured within the European Cancer Pulse. And also we're delighted that our 42 member organizations within the European Cancer Organization and the 20 plus members of our patient advocacy group are also providing data that allows us to populate the different areas of the European Cancer Pulse. And there is a submission system for external data sources to be uploaded for the European Cancer Pulse to become as comprehensive as possible. Just if you look at some of the snapshots of some of the data that we've already captured, if we look at national cancer plans, only 12 of the 27 EU countries have an updated national cancer plan. So obviously it's important that the other 15 have updated plans that are properly resourced and implemented. If we look at differences in diagnosis, you can see there only 8% of Dutch citizens experience difficulties in finding information about cancer symptoms if we compare that with 40% in Bulgaria. So these are the type of inequalities that are really not acceptable in Europe, and we really need to do something about it. But in order to do that, we need to have the cancer intelligence that tells us what are the challenges, where are the weak points, where are the areas that we need to actually address, how do we do this, and how do we use the data intelligence to help us in terms of policy change in particular. You can see there other examples, CT scanners, UK 1 per 100,000 compared to 3.5 in Germany, medical personnel, oncologists per 100,000, you can see Sweden almost 6, Malta less than 2, nursing Norway 1,788 nurses per 100,000 inhabitants, only 338 in Greece. So we're really starting already to see some of the inequalities that are being highlighted by the European Cancer Pulse. Very important that we capture information in relation to cancer survivorship. There are over 20 million European citizens living beyond cancer. We need to represent them more fully, and part of that is capturing data in relation to what is happening to our European cancer survivors. And also it's really important that cancer patients have appropriate access to financial services. And Françoise Meunier has been leading an initiative called the Right to be Forgotten for cancer patients that we're delighted to work with her on. And looking at the moment, we can see that legal implementation of the Right to be Forgotten is only in a small percentage of EU countries. We need to increase that dramatically, and we're seeing that starting to happen, but also we need to capture data to help inform the right to be forgotten. And you can see their spend in relation to healthcare, also in cancer care, Romania, compared to Austria. You can see there almost a fourfold difference in that particular area. The other important thing that we're capturing is the information in relation to research. I'm delighted to say that the European Ground Shot Commission has been launched by the Lancet Oncology. I was privileged to lead this initiative involving nearly 50 experts, both patient and oncology experts from right across Europe. And what we wanted to do was address what are Europe's cancer research challenges. And in order to do that, we need to look at what is the data telling us in terms of cancer research activity currently in Europe. Unfortunately, what it's telling us is that Europe is facing a cancer crisis. The combined impact of the COVID-19 pandemic and subsequent national lockdowns, the Russian invasion of Ukraine, the overall global economic downturn really means that we need to act now. And in order to act now, we need to have cancer intelligence that tells us what's happening currently and where do we need to invest, where do we need to drive cancer research activity so that we might do better in the future. We have developed very detailed data intelligence in relation to cancer research in Europe, and that's underpinned 12 recommendations really to reimagine cancer research and its implementation across Europe. And this is very much addressing the realities on the ground. So this is not shooting for the moon. This is very much a ground shot looking at what are the key challenges that we face and how can we use research to address these challenges. You can see here, I've highlighted this from the Lancet Oncology Commission that we wrote. Too often opinion, even expert opinion, has trumped data in the genesis and implementation of cancer research policies. We want to change that so that we really have a cancer research culture that delivers pragmatic, patient-focused solutions for Europe. And it's really important that we do this in a way that gathers data, uses that intelligence to really inform a better approach, a reimagination of cancer research activity in Europe. And critical to this is our 70-35 vision, 70% long-term survival by 2035. As I said, not shooting for the moon, very much grounded in reality, hence the term, the European Cancer Ground Shot. We want to achieve this long-term vision for the 20 million people living with cancer across Europe. And one of the things we found from this commission, and again, it underpins the importance of data and data intelligence, that patients who are treated in research active hospitals have better outcomes than those who are not. So this means that research is not a luxury. It is an essential and an integral part of modern European cancer care. And that needs to be delivered no matter where you live in Europe. This is just showing you, just dipping into a couple of examples from what the data has shown us. What you can see here is activity in Central and Eastern Europe as compared to Western Europe. What you can see there is in the EU15, which is essentially Western Europe or predominantly Western Europe. You can see the cancer research activity has greatly, in fact, has doubled over the last period of time. You can see here, if you compare that with Central and Eastern Europe, you can see really there's been stagnation, little or no progress. And unfortunately, this is having a direct impact on survival and outcomes in Central and Eastern Europe. So this data intelligence, which is being captured as part of the European Cancer Pulse, then points in the direction of what we need to do. So capacity building, directed funding, twinning, to enhance the research activity, the quality and its translation, particularly in Central and Eastern Europe. So it should be that all citizens and patients, no matter where they live, are able to benefit equally from advances in cancer research. And this just shows you the 12 recommendations that we've made in the European Cancer Ground Shot Commission based on the evidence that we've collected. And you can see there that doubling activity in relation to health service research and implementation science. You can see there making sure that all Europeans benefit from cancer research no matter where they live. I'm not going to go through all 12, you can see them there, but what you can see there is that everything that we've emphasized here is underpinned by data. So underpinned by data intelligence, that's what the commission was set up to do. And we've worked on the last 2.5 years to develop this very detailed, the most comprehensive assessment of cancer research activity, and then has underpinned these 10 recommendations, which, if they are addressed and adopted, would really mean, one, a complete sea change in relation to cancer research activity in Europe, but also the impact on better survival, better outcomes, earlier diagnosis, better treatment for cancer patients. So I'd like to thank you for your attention. I hope that you will all go to the website, look at the European Cancer Pulse. Also, I've indicated in the slides the European Cancer Ground Shot, and as I said, it's now out in Lancet Oncology. So again, would encourage you to look at that, and really to thank you for your time, and hope that the rest of the colloquium goes very well for you. Thank you very much indeed.
I'm Ian Olver from the University of Adelaide, and on behalf of MASCC, I'd like to present this update of financial toxicity. So what is financial toxicity? Well, it's the unintended potential economic harm or damage of, in this case, cancer treatment. And it has two components: an objective component where it impacts both the patient and the household because expenses override savings. And it requires the redistribution of this financial burden with a long-term agenda of mitigating the underlying causes of the toxicity. But it also has a subjective component where this financial situation causes distress as a reaction to it and results in a reduced quality of life, which can compromise treatment and worsen the outcomes. Attempts at measuring financial toxicity have included a scale which Geriatric reported, which simply assesses the financial burden based on the ability to pay, and it may range from a mild financial burden where the household income can be maintained, but to a catastrophic burden where the replacement income cannot meet the requirements of running the household. But then there's a more comprehensive score that De Souza described called the cost score, and this has both the financial toxicity objective and subjective criteria together. So there is a scale about the worry and the stress of the financial burden, as well as measuring the burden itself. Now, in 2022, we've had a number of papers, and I've selected some of them to show some of the advances in financial toxicity, but I want to, in the second half of this talk, actually concentrate on the ones that are not just looking at the causes of financial toxicity, but are starting to do trials to mitigate that toxicity. First of all, though, I think it's important to note that although financial toxicity was first described in high-income countries, it's actually a problem in low and middle-income countries. And this paper by Donker and others in supportive care in cancer included 31 studies in a systematic review and meta-analysis. And what it found was that the objective financial toxicity in low and middle income countries where it was recorded runs at around 57%. Very few of the studies actually reported subjective toxicity, but one that did put it at 35.4%. And in fact, in this paper, the chances of financial toxicity is higher if the household size is greater than 4 people, if the patient is having more than one cycle of chemotherapy, and depending on whether they have private health insurance or are being treated in a private health facility. And in terms of mitigating strategies, there's the individual's ability to use up personal savings and to borrow against and create a bank debt. There are people that are related to those in financial distress who might be able to provide some support, at least emotional support. The community, particularly the workplace, may have a financial assistance program. And then there may be policies within a society that provides a social support program, such as food or accommodation for those in stress. Now, if we look at the risk factors of financial toxicity in cancer survivors, so that extends it beyond just people that are undergoing treatment, there was a systematic review and meta-analysis by Giannis, where the prevalence of risk factors in cancer survivors was measured between 2010 and 2021. And they found the prevalence of financial toxicity to be estimated at about 45%, which is in the same ballpark as we saw with the low and middle income countries. They looked specifically at the risk factors, and some of them are clear: a low income, greater out-of-pocket expenses in terms of the cost of the treatment, those of a younger age who presumably hadn't accrued much in the way of savings, the lack of private health insurance, being unmarried, so being solely responsible for the finances, non-white people in certain societies. Advanced cancer was far more problematic because it's usually more expensive than early stage cancer. Being unemployed when you were diagnosed with cancer is certainly a feature, and those that with a more recent diagnosis were in more trouble than those whose diagnosis was in the past, because many of the costs of treatment are up front. Just to look at some very specific causes of toxicity, and I think this one will not be a surprise to anyone, but it hasn't been formally studied, and that is parking related to financial toxicity. And Belushi et al. Reported from 4 Canadian provinces a study that looked at the cost of parking. It was a cross-sectional study between February and March in 2022. And they found a correlation between the daily cost of parking for patients and the city cost of living. But they also found a correlation between the cost of parking and the cost of actually getting to a cancer centre, the so-called transit score. And the fact is, the cities that had more free parking often have less public transport, so the two are balanced. And what this means is that the cost of parking can certainly contribute to the financial burden, but it can also contribute to loss of wages if you have to spend a long time transiting to your particular cancer treatment centre. And what about income? Well, this study from Japan showed the change in income 1 year after a cancer diagnosis. They sent out questionnaires to people who had reached that stage, and 72 eligible questionnaires were analysed. And what they found was the mean year-on-year income 1 year since the cancer diagnosis was 66%. In other words, patients had lost a third of their pre-cancer income when they went back to work. There was a fair range of this, but the median loss was about 30%. So the factors here were younger. So younger people were often down at about 50% of their income post-cancer, compared to older people who were 74% of their pre-cancer income. It was worse if you had advanced cancer, which was not surprising. It depended on your employment status at diagnosis, and they excluded patients who were unemployed, but those who were part-time certainly had a far greater trouble accruing income after their cancer diagnosis than those who were working full-time. And it was clearly an advantage to continue to be employed at the same workplace as you were before your cancer diagnosis. So there was almost half the chance of pre-cancer income if you only had a part-time job. And the little graph at the bottom shows that some patients actually increased their income. To the right of the graph, about 20 of the 72 had up to 110% of their pre-cancer income. Some had none at all, and the vast majority were clustered in the centre, around 30 to 40% loss of income a year after the diagnosis. Now, what about this question of younger versus older adults? Well, a study by Corrigan published in Cancer compared 18 to 39-year-olds with 40 to 60-year-olds and those over 65. They surveyed 311 adults using the multi-domain economic strain and resilience in Cancer Institute to assess financial toxicity, and this has a scale of 0 to 10. All the participants were receiving ambulatory care, and young adults made about 9.6% of the population surveyed, and other working adults were 56.9%. And the results showed that younger adults did fare a lot worse than older adults in terms of experience from financial toxicity, both in terms of material hardship, coping with the resource depletion and the psychological burden. And it was the younger people who tended to have the more severe financial toxicity versus older adults. But as I mentioned, I think the thing that was particularly important about the papers published in 2022 is we began to look at lessening the impact of financial toxicity. And this trial reported by Wheeler, called the LIFT trial, is a trial of using financial navigators, seeing if you can implement that and how it will impact on patients. And they had 780 patients in 9 oncology settings, both rural and non-rural, and they had access to financial navigators. And they measured the changes in this global cost financial toxicity score, as well as health-related quality of life, whether they had to delay or forgo treatment, and in general, the uptake of services. And what they found in this ongoing trial was 3 components. One was that the financial toxicity screening and identification and intake assessment was going to be assessed in this study. They wanted to study how well patients were connected to financial support services, and finally, they wanted to track the patients over time and see what the outcomes, the longer-term outcomes of having access to financial navigators. So this will be an important study that will tell us a lot about whether financial navigators are an important strategy to provide patients with the support as early as possible if they're going to experience financial toxicity. There was also a study by Longo and others who particularly asked caregivers, social workers and survivors about what their experience of financial toxicity is. And this was a qualitative study of 22 stakeholders. And the findings were that what they really wanted was practical support. And this has been a feature of a number of studies over the years, that the best thing to do is, if there is an access to funds or vouchers, to actually give them money to get over the financial barriers that they're facing. But they also said that it's useful if they know in a hospital system who does what, that people have clearly defined roles, because all sorts of people could be impacting on financial toxicity, and all sorts of people could provide services. And that required also the timely flow of information so that you can identify and address financial toxicity early, but also so that patients know early on what services are available and how to access them. And finally, there's a proactive type of navigation where patients are not just assessed at the beginning, but they have regular reviews that there are navigators who will advocate for them and provide them useful tools such as question prompt lists to ask their oncologists about the cost of treatments and so on, but also practical things to see, particularly if rural patients can reduce unnecessary visits if a follow-up appointment could be done locally with communication with the oncologist, for example. Of course, it would be important to find what medical oncologists can do in terms of at least discussing cost with the patients. And an interesting study was published from Australia where 106 out of 547 Australian medical oncologists surveyed, and 66% agreed that they should discuss financial issues with their patient. However, only 25% had in fact discussed it with 50% of the patients. And on the graph there, you see that very few discussed it with all the patients. Very few didn't have any discussion at all, but most of them discussed it with less than half of their patients. And when the oncologists were provided with data about what strategies they could use and what would be useful for them to increase the discussion, if you look at the purple components of the bars, they thought a website to refer patients to, handouts that they could give the patients that would provide background information and guidelines for this would be extremely helpful. Just general information like posters in waiting rooms, perhaps not quite so much. The other thing, of course, would be what about if you could access your medications at the best cost available? And in fact, this study from Canada from the United States is quite interesting, because if you were trying to access your medications from the best, cheapest pharmacy, it turns out that no single pharmacy is consistently the least expensive. So what these investigators did is examine the pricing of 14 nausea and 12 cachexia formulations over 8 US Minneapolis pharmacies, comparing discounts over two months. And across pharmacy formulation combinations, there were enormous variations in price over time, ranging from minus 76% to plus 292% for the same medication. So for almost half of the formulation studied, at least one pharmacy with the lowest price was no longer the least costly a few months later. And the lowest price for a formulation across pharmacies could also change considerably over time. The most outstanding example was a formulation where the cheapest became the dearest when the price increased at 85% of the original price. And the problem with this is what the authors called a logistic toxicity, where you had to go pharmacy shopping every time you wanted to replenish your stocks of supportive care medication. But that, of course, also is unsafe. It increases the risk of errors if you're using multiple pharmacies. So I think here's an issue that could be addressed as part of the overall problem of reducing financial toxicity. But what about the value of therapy and reducing perhaps unnecessary therapy? And Merrick and others are reporting on the REFINE trial, which was a trial reducing the frequency of immune checkpoint inhibitors used in cancer. And this is a randomized phase 2 multi-arm, multi-stage adaptive basket trial. And what it was doing was investigated whether you could extend the interval of administration of immune checkpoint inhibitors, given that pharmacodynamic studies indicate that despite a low pharmacological half-life of 2 to 3 weeks, the target occupancy is considerably longer. So what they were doing is looking in those who had responded to immune checkpoint inhibitors, whether in the maintenance phase they could have treatment every 8 weeks instead of every 4 weeks. And the initial study patients were being treated with nivolumab in renal cell carcinoma, and the assessment was performance-free survival. And this study is ongoing. So it's about the value of the treatment and whether patients can be given less treatment without compromising their outcomes. So in conclusion, there are ongoing trials and strategies to reduce financial toxicity. I think it'll be very important to know whether the provision of patient navigators specifically trained in this area will be helpful. Certainly the patients and their relatives want better communications about the cost of treatment when they see their oncologist, but also the resources available within the system to mitigate that. And then in terms of treating cancer, we need to ensure value-based pricing to help patients make their treatment choices. And this is the sort of thing that the Multidisciplinary Association for Supportive Care in Cancer is interested in and take part in the research. We get together annually at a meeting. In 2023, it will be in Nara in Japan. And I look forward to seeing the results of the trials of strategies to mitigate financial toxicity. And I thank you for participation in this OncoAlert Colloquium.
I'm Dr. Charles Blanke, a professor of medicine with the Knight Cancer Institute at Oregon Health and Science University, and chair of the SWOG Cancer Research Network, part of the National Cancer Institute's National Clinical Trials Network. SWOG is proud to partner with the OncoAlert Colloquium to help inform the oncology community about some of our most significant findings from 2022. I'll present a selected set of results from both individual clinical trials and data analyses, plus one or two looks ahead. These are not by any means all of the significant results we reported in 2022, but are some of the most important ones that grouped readily into themes or disease areas that could be covered in a brief presentation. These are the topics I'll cover. We will explore lung and breast cancer, melanoma, genitourinary tumors, and cancer care delivery. The first two studies I want to present are lung cancer trials, one recently completed, the other just opening. S1800A is the first positive sub-study from the LungMap master protocol. As study PI Dr. Karen Reckamp reported at ASCO 2022, S1800 demonstrated that in patients with advanced non-small cell lung cancer that had progressed on prior immunotherapy, the combination of ramucirumab plus pembrolizumab reduced the risk of death by 31% compared to standard of care treatment. This is the first trial to show a survival benefit in these patients from combining an immune checkpoint inhibitor with a VEGFR2 inhibitor. Follow-up findings Dr. Reckamp presented at ESMO 2022 from an exploratory analysis of S1800A data indicate that these overall survival benefits were observed regardless of the length of time patients had spent on previous immune checkpoint inhibitor therapy and regardless of their response to that prior therapy. The results of 1800A have led to an FDA breakthrough designation for the combination the trial tested. They've also led to the launch of a landmark validation trial, which may significantly change the way federally funded oncology research is conducted. The phase 2 S1800A enrolled 136 patients. To confirm the benefit demonstrated in that small trial, we've developed the phase 3 S2302 Pragmatica lung trial. In collaboration with many of the organizations we partnered with on LungMap for almost a decade now, plus with key strategic guidance from the FDA's Oncology Center of Excellence, we designed a significantly streamlined pragmatic trial, and we wrote the protocol, moved it through approvals, and have brought it to activation in record time. As I record this presentation in early January, we're on target for a mid-month or end-of-month activation. What do I mean when I describe the study as significantly streamlined? For starters, it has only two objectives. One, compare overall survival between arms, and two, summarize adverse events that are grade 5 or AEs that are grade 3 or 4 if they are serious or unexpected. We've also stripped down the eligibility criteria. The trial will enroll adults, performance status 0 to 2, with stage 4 or recurrent non-small cell lung cancer, who received prior chemotherapy and have acquired resistance to immunotherapy. The protocol fleshes out a few additional eligibility criteria, but that's essentially it. The bare bones eligibility requirements mean the trial can enroll a group of patients who represent a huge portion of the entire spectrum of patients with this disease. And to ensure we can enroll these patients quickly, we've tried to make it extraordinarily easy for all sites to open and conduct the trial. Site staff don't need to collect specimens, images, or patient-reported outcomes. The number of data elements they have to collect and the frequency of collection have both been minimized. The net outcome is a model for a much leaner study, one that can be easily run everywhere care is provided, and that can provide trial access to an incredibly diverse group of patients. And it can still serve as a registration trial. We've worked closely with the FDA to ensure it will provide the data they need to make a decision. Now we'll move on to breast cancer findings. The SWOG S1007 responder trial, the previously reported results showing that postmenopausal women with hormone receptor positive, HER2 negative breast cancer who had 1 to 3 involved lymph nodes and a 21 gene recurrence score of 25 or less could safely forego adjuvant chemotherapy. 2022 saw the presentation of important follow-up analyses of data from that trial, which had enrolled more than 5,000 women. At the 2022 San Antonio Breast Cancer Symposium, Dr. Yara Abdu presented analyses of the association of patient race and ethnicity with clinical outcomes. Her team found that 5-year invasive disease-free survival, the trial's primary endpoint, was statistically significantly lower for non-Hispanic Blacks than for Asians, non-Hispanic whites, or Hispanics. These results were independent of recurrence score, treatment arm, patient age, and disease grade, though the limited number of patients in the non-Hispanic Black cohort meant that definitive conclusions cannot be drawn about racial differences in treatment benefit. Also working for responder data and reporting at San Antonio, a team led by Dr. Irene Kang analyzed patient-reported cognitive impairment over time across the trial's 2 arms and by patient menopausal status. Their analysis showed cancer-related cognitive impairment was greater with chemoendocrine therapy than with endocrine therapy alone. On average, patients on both arms tended to suffer cognitive impairment at the 6-month and 12-month marks during treatment. However, by 36 months, patients on the endocrine therapy only arm had recovered baseline cognitive function. Those who received both endocrine therapy and chemotherapy, mean scores remained below baseline levels at 36 months. Finally, Dr. Reshma Jagzi led an analysis which she presented at ASTRO 2022 of the use of radiation therapy with patients on their responder trial. Her team specifically looked at whether patients needed regional node radiation to reduce their risk of local regional recurrence of their disease. They found rates of local regional recurrence were low, regardless of whether patients had received regional node radiation. Dr. Jagzi emphasized that the results of the analysis highlight the importance of rapidly completing the ongoing TAILOR-RT trial, MA39, which is led by the Canadian Cancer Trials Group with NCI co-sponsorship. 3 SWOG melanoma trials reported significant results this year that may change clinical practice or already have. The first of these is the SWOG S1512 trial in patients with desmoplastic melanoma, results of which were reported at ASCO 2022 by study PI Dr. Terri Conner. Desmoplastic melanomas tend to occur on areas of the body that have been heavily exposed to UV light, which are often prominent areas such as the face, neck, and shoulders. S1512 found that neoadjuvant PD-1 blockade therapy can significantly shrink these tumors, potentially reducing the extent of surgery and radiation needed, which otherwise could be disfiguring. The trial enrolled 29 patients with desmoplastic melanoma that was considered to be operable. All were treated with 200 milligrams of pembrolizumab every 3 weeks for an average of 3 cycles before surgery. Of the 29 patients, 16 showed a pathologic complete response to immunotherapy, and 92% of patients showed some response, suggesting a high potential for further benefit. I want to highlight that the trial did not directly test whether successful neoadjuvant immunotherapy resulted in less extensive surgery and radiation, but the frequency and extent of the clinical responses suggest they still may significantly reduce the extent of the potentially disfiguring surgery needed by these patients. These results are already changing clinical practice. Our second melanoma trial is SWOG S1616. Dr. Ari Vanderwall presented results at the clinical trials plenary session of ASCO 2022. S1616 was a phase 2 trial that enrolled patients whose advanced melanoma had been treated with a PD-1 inhibitor but had not responded. Such patients often move next to treatment with a CTLA-4 inhibitor such as ipilimumab. S1616 asked whether the CTLA-4 inhibitor should be given alone or whether a PD-1 inhibitor should be continued with it. The answer seems to be the drug should be given together. S1616 randomized 92 patients to either ipilimumab alone for 12 weeks or the combination of ipilimumab and nivolumab for 12 weeks, followed by monthly nivolumab for up to 2 years. 6-month progression-free survival estimates were 13% for patients on ipi alone versus 34% for patients on the combination arm. The objective response rate was also significantly better for the combination. The third set of high-impact melanoma results were from the phase 2 S1801 trial, which study PI Dr. Sapna Patel presented at a presidential symposium at the ESMO 2022 Congress. This study enrolled 345 patients with resectable stage 3B through 4 melanoma and randomized them to either upfront surgery, followed by 18 cycles of pembrolizumab, or 3 cycles of pembrolizumab before surgery, followed by 15 cycles of pembro after surgery. With a median follow-up of 14.7 months, event-free survival was significantly greater on the neoadjuvant therapy arm, with an event rate 41% lower than the rate on the adjuvant therapy arm. The study team found this benefit from neoadjuvant therapy was consistent regardless of patient age, sex, performance status, disease stage, or BRAF status. Notably, the same proportion of patients made it through surgery to adjuvant pembro in both arms, and the rates of adverse events attributable to pembrolizumab or surgery were similar across arms. These results are also changing clinical practice. In genitourinary cancers, a SWOG team working with samples and data from the S1314 trial in muscle-invasive bladder cancer demonstrated that methylation patterns in cell-free DNA in peripheral blood can be used not only for tumor detection, but also for predicting patient response to chemotherapy. Led by Dr. Amir Goldkorn, the group extracted cell-free DNA from blood samples collected, both before chemotherapy and after one cycle, from 73 patients with muscle-invasive bladder cancer who were enrolled to S1314. By analyzing differences in methylation patterns in the DNA and working with clinical data on tumor response, they developed a predictive methylation-based response score, or MR score. They also used the methylation data to calculate what fraction of a patient's cell-free DNA was from the bladder. Combining this calculation with the MR score, they could correctly predict in 79% of the patients they had tested whether tumors would respond to neoadjuvant chemotherapy. The work provides a proof of concept and needs further validation, but being able to read a biomarker in this way from a liquid biopsy could help physicians identify which patients with muscle-invasive bladder cancer are likely to benefit from chemotherapy before their surgery and which patients could safely skip it. The results were presented at ASCO 2022. The other finding I want to highlight in GU is also in bladder cancer. The joint SWOG NRG S1806 study in patients with non-metastatic muscle-invasive bladder cancer is testing adding immunotherapy with atezolizumab to standard trimodality therapy of endoscopic surgery plus chemoradiation. The goal is improved treatment options for these patients that are more likely to allow them to keep their bladder. This is the largest cancer trial in North America investigating bladder-preserving therapy. To ensure patients on the immunotherapy arm of this trial aren't facing significantly increased toxicities compared to their counterparts on the control arm, the trial team has conducted interim toxicity and assessments, and they presented such an assessment at the ASTRO 2022 meeting in October. Dr. Parminder Singh was lead author on that report. Their analysis of data on 213 patients enrolled to the trial found that 58% of those on the immunotherapy arm reported grade 3 or higher toxicities, compared to 44% of patients on the control arm. Most reported toxicities were hematologic and were not considered to be immune-related by the treating physician. An earlier pre-specified safety analysis of the first 80 patients enrolled in the trial also found no significant increase in toxicity on the investigational arm as compared to control. The findings of no safety concerns with the trial's chemoradiation and immunotherapy combination means the study can continue to enroll patients. The S1806 study is accruing well and is expected to reach its goal of enrollment of 475 patients within 2 years. SWOG also reported several important cancer care delivery research results in 2022. I'll start with S1417-CD. S1417-CD was the first study to prospectively measure the financial impact of cancer treatment in a socioeconomically and geographically diverse nationwide group of patients newly diagnosed with advanced cancer. Led by Dr. Veena Shankaran, the trial enrolled 380 patients recently diagnosed with colon cancer that had metastasized. Patients completed questionnaires every 3 months for a year about their financial, employment, and insurance status, and about their quality of life and whether they were experiencing physical, functional, cognitive, emotional, or social problems. The S1417-CD team found that although 98% of the enrolled patients had health insurance, 71.3% of them experienced financial hardship, major financial hardship, during the first year after their diagnosis. Major financial hardship was defined as experiencing at least one of the following: an increase in debt, taking on a new loan, selling or refinancing a home, or experiencing a drop in income of 20% or more. The team also reported that major financial hardship was associated with a subsequent drop in patient social functioning and quality of life. One goal of the study was to determine whether it was even feasible to collect financial information in this way from patients with advanced cancer, or whether concerns about issues such as privacy and data security would keep patients from joining the trial. Clearly, it is feasible, and Dr. Shankaran's team recently launched the S1912-CD trial, which is now enrolling patients to test whether a financial counseling intervention can help ease financial hardship for those being treated for cancer. The SWOG Cancer Research Network has been conducting clinical trials in cancer for more than 60 years, and we've amassed a huge database of clinical information that is regularly mined and analyzed to generate important insights that can change how we care for patients. Among the analyses of that data we published in 2022 was assessing the association between a patient's gender and their risk of severe adverse events from cancer therapy. It has long been known that when treated with chemotherapy, women are more likely than men to experience severe treatment-related adverse events. A group led by Dr. Joseph Unger wanted to know whether there were also associations between a patient's gender and their risk of severe adverse events from two other major cancer therapy modalities, targeted therapies and immunotherapy. The team analyzed data on more than 20,000 patients who had enrolled to more than 200 SWOG cancer clinical trials over a 30-year period. They found that women do also have a higher risk of severe adverse events from both targeted and immunotherapies for cancer. When all three modes of therapy were considered, women had a 34% higher risk of severe toxicity than men. The increase in risk was most pronounced for immunotherapy, where a woman's risk of a severe adverse event was 49% higher than a man's risk. Dr. Joe Unger also led an analysis of data collected from the trial databases of all four of the groups within the NCI's National Clinical Trials Network that focused their research on cancer in adults: the Alliance, ECOG Akron Cancer Research Group, and Energy Oncology, in addition to SWOG. The analysis looked at the impact and the cost of the last 4 decades of NCTN clinical trials in adults. The 162 phase 3 trials that have published positive results since 1980 were collectively estimated to have extended the lives of patients with cancer in the US by at least 14.2 million life years. Importantly, the study that also estimated the cost of those gains have been quite modest, roughly $326 in federal investment for each life year added. The research team further quantified some of the enormous clinical and scientific impact of these NCTN trials. Overall, the primary findings of the 162 analyzed studies were cited in the scientific literature more than 165,000 times through the end of 2020, and 87.7% of the trials have been referred to as evidence in subsequent cancer care recommendations made in widely used guidelines. Numerous other important presentations and publications of SWOG research saw light in 2022, but this focus on overall impact of the NCTN is a good place to end my presentation. I want to close by thanking OncoAlert for the chance to present to you on some of the most significant results from SWOG's work in 2022. Thank you.
Dear colleagues, thank you very much for joining us on this day 3, and please join us tomorrow when we'll be covering the ASTRO sessions by Dr. Mirza, LaRusso, Fotopalau, melanoma and sarcoma by Dr. Spetov-Warner and Trent, and finishing up with Dr. Krul of the European Cancer Organization. We look forward to seeing you tomorrow, and thank you for your attention. Until then, thank you for sharing this colloquium, and thank you for being OncoAlert.